Good afternoon. Greetings from Merck. Merck is honored to partner with TAPISOR in your scientific and academic activities. So Merck has a very long history of 350 years, and during this time, Merck has grown more than a pharmaceutical company to science and technology business, so which includes also healthcare, life science, and performance material. So Merck has been in India for more than 50 years. So in healthcare, Merck works with the goal to improve, prolong, and also create life. So we have the cardiometabolic business, which helps on improving life. And we have oncology business, which helps to prolong life. And fertility business, with its innovative and state-of-the-art products, we partners with you to create life and spread the joy of parenthood to lots of couples who want to start a family. So we always valued research and also academic and scientific activities. And we wholeheartedly support TAPISOR in this endeavor. I thank Dr. Sanjeeva Reddy for giving us an opportunity to take part in this webinar. Have a good session ahead. Over to you, sir.
Thank you, Vijay. From the day one, they are supporting TAPISOR from the time of inauguration. Thank you very much for sponsoring this session. Good afternoon to you all. This is our 13th webinar during this after lockdown periods. So this time there is a speciality. We have chosen previously different topics we will be choosing, even though the speakers are from all over India. This time we have decided we'll go for the specific topic like polycystic ovary syndrome. I thank all the participants, faculty, and companies who are supporting this one to making it a success. And you can see the speakers from Delhi to Kerala. We have selected all the speakers and the very senior, experienced and expert moderators to extract the answers from the speakers. It is up to you how to utilize this session and get maximum knowledge from the speakers. First, I will introduce our first moderator, Dr. Niranjan Chavan. He is the Professor and Unit Chief, LTMMC and LTMGH CN Hospital, National Coordinator, FOXI Medical Disorders Committee, Vice President Marks, Scientific Secretary AFG, Member Managing Committee IAGE, Joint Treasurer-elect FOXI, Chair and Convener FOXI Cell Violence Against Doctors, Dean and Chief Content Director, High Grade E3 Courses, Chief Editor, AFG Times, Chairperson, FOXI Oncology and TTD Committee, Course Coordinator of 11 batches of MUHS Recognized Certificate Course of BAM IE at LTMGH, Member, Oncology Committee, AOFOG, Editorial Board, European Journal of Gynec Oncology, Course Coordinator of 3 batches of Advanced Minimal Access Surgery. So, you know, like you can see how experienced he is. Niranjan,
Yes, sir. Thank you, sir, for giving me this opportunity and for moderating this session. And today I would like to thank Dr. Pratik Tambe, Science Integra, and most importantly, Dr. Sanjeeva Reddy to start this TAPISOR webinar in collaboration with Merck. And we have with us today an eminent speaker, Dr. Raghavendra Prasad, MBBS DGO DNB. He is the Director of Infertility and Feto-Maternal Unit at Sunrise Hospital, Kanangad, Executive Director in ARMC IVF Mangalore, Consultant in International Modern Hospital Dubai, and President of Kasargod Obstetrics and Gynecology Society. An eminent person in the field of infertility, and his topic today is adolescent PCOS. So I welcome Dr. Raghavendra and hand over the mic to him to start his presentation. Thank you so much.
Thank you, sir. Thank you very much for the kind introduction. I would like respected chairperson and seniors and my dear colleagues. First of all, I would like to thank Dr. Reddy sir for having given me this opportunity. I'll just Is the slides visible?
Yes, put in the slideshow mode.
Yeah. I think the slides are visible, right?
Yes, yes.
Yeah. Okay. The topic given to me today is about adolescent PCOS. As we know that every now and then in our OPDs, we have quite a lot of women coming to us stating that my daughter is having PCOS. This is the direct thing they come to us with. Not directly they come to us with the diagnosis telling I think my daughter is having PCOS. Or the mother comes and tells my daughter is having too much facial hair or too much body hair. Can you do something about it? So when you look at it, polycystic ovarian syndrome is the most common endocrinal pathology, affecting around 6 to 18% of adolescent girls. So WHO defines adolescence as a period between 10 to 19 years of age that brings about a significant changes in growth, development, and puberty. So we all know that PCOS is a syndrome characterized by amenorrhea or oligomenorrhea with laboratory criteria of hyperandrogenemia and hyperinsulinemia and a polycystic ovarian feature on ultrasound. This syndrome was first defined by Steen and Leventhal in 1935. He included almost all the features: polycystic ovarian morphology, menstrual irregularity, hyperandrogenism, and central adiposity. But the latest criteria, a few of the features have been removed. So when you talk about adolescence, what is the criteria which matters the most? One is the irregular menstrual cycle and ovulatory dysfunction. So when you have an irregular menstrual cycle, you need to think first of PCOS. So cycle interval varies according to the time post-menarche. And we know that an ovulation is a very common physiological event because of the delayed maturation of the hypothalamo-pituitary ovarian axis in some of these girls. So it may not match the same cyclicality which is seen in women of the reproductive age. So when you define an irregular menstrual cycle, we go according to the time post-menarche. So in less than 1 year post-menarche, irregular menstrual cycles are a normal pubertal transition. In between 1 to 3 years, anything less than 21 or more than 45 days is abnormal. And anything more than 90 days definitely needs to be evaluated. And 3 years after menarche, a cycle between 21 or more than 35 days or less than 8 cycles per year definitely needs to be evaluated. So primary amenorrhea by age 15 or more than 3 years after post-menarche again is considered abnormal. So when you have the clinical features or the biochemical features, you look for one biochemical features of hyperandrogenism. So you look at calculated free testosterone, free androgen index, or bioavailable free testosterone. Now, androgen level in adolescents normally reach the adult level around the time of menarche. Now, when you look at the other two steroids, the androstenedione and DHEAs, it is more useful in excluding other causes of hyperandrogenism. So when you have an androstenedione elevation, it is mostly seen in non-classical adrenal hyperplasia. And DHEAs is a predominant adrenal androgen, and mild elevations can be seen in PCOS, whereas significant elevations can be seen in androgen-secreting tumors. So when you evaluate for the hormones, we should see to it that the person was not on any hormonal medications for the prior 3 months. Then you look at the clinical hyperandrogenism. So when you look at the clinical features, you have to have a comprehensive history and a physical examination, which should be completed to look for signs and features of hyperandrogenism, which in adolescents will look at acne and hirsutism. So mild commodal acne is a common feature in adolescents, but moderate or severe commodal acne, that is more than 10 lesions, facial lesions, in early puberty or moderate to severe inflammatory acne during the perimenarchal year is uncommon, and it is most likely to relate to clinical hyperandrogenism. You look at hirsutism, and as we know that hirsutism is commonly evaluated using a modified Ferriman-Galway scoring with a level of more than 4 to 6, which indicates hirsutism. So what is Ferriman-Galway scoring? It evaluates the terminal hairs that would grow more than 5 millimeter in length, and if left intact, are usually pigmented and medullated. It is looked for in 9 primary and androgen-dependent areas, commonly the upper lip, the chin and neck, upper chest, excluding the nipples, upper abdomen above the umbilicus, lower abdomen, thighs front or back, upper back, lower back, and upper arms. Each area is visually scored from 0 to 4. There is no terminal hair visible as 0 to hair consistent with a well-developed male is 4. So over 50% of women with a score of 3 to 5 and over 70 to 90% of women with scores of more than 5 have elevated androgen levels or PCOS. So higher hirsutism levels are usually related to higher testosterone levels. What investigations are not recommended in adolescents? One is ultrasound, pelvic ultrasound for PCOS diagnosis. So we do not base our diagnosis for PCOS based on an ultrasound in adolescents. So pelvic ultrasound should not be used for the diagnosis of PCOS in those with gynecological age of less than 8, that is less than 8 years post menarche, due to the high incidence of multifollicular ovaries in this particular stage. The maximum ovarian volume is attained at the age of 20 years. Anti-Mullerian hormone level also should not be used as an alternative for the detection of PCOS or as a single test for the diagnosis of PCOS in the adolescent age group. PCOS is basically a diagnosis of exclusion, and the most common amenorrhea in a sexually active girl would be pregnancy, which is not that common in probably in our setup. So menstrual irregularity alone could be due to gonadotropin deficiency caused by a functional hypothalamic amenorrhea, secondary deficiency due to any systemic causes, or to a primary gonadotrophic defect. Again, as I told you, the most common condition is a non-classical CAH, where you have a marked elevation of androgen levels, that is a deficiency of 21-hydroxylase enzyme due to the mutation in the gene. So diagnosis of congenital adrenal hyperplasia is suspected if an adolescent girl has clitoromegaly or an elevated early morning follicular phase level of 17 OHP, and it is confirmed with a 17 OHP level elevated after 60 minutes after administration of ACTH hormone. You have to rule out hypothyroidism, hyperprolactinemia, glucocorticoid excess due to Cushing's disease, glucocorticoid resistance, and androgen secreting ovarian or adrenal tumors, which can cause menstrual irregularity and hyperandrogenism. You need to measure the thyroid levels, the prolactins, the gonadotropins, and follicular level of 17 OHP also. Now, what are adolescents at risk of PCOS? The timing is at 3 years post menarche in relation to the menstrual cycle irregularity, and at 8 years post menarche in relation to the use of pelvic ultrasound to identify a PCO morphology. So this rules out basically the immature hypothalamo-pituitary axis. And once you identify these candidates, these adolescents should be made aware of at their risk status for PCOS, and a future re-evaluation may be needed if both features persist beyond 3 years post menarche. Now, one thing which when we sit in our OPDs, what we are not very good at is assessing the emotional well-being of the individual. Odds of moderate to severe depressive symptoms were increased, as also were the odds of moderate to severe anxiety symptoms independent of obesity. Guideline recommends routine screening of these conditions in all adolescent and women at diagnosis, with further evaluation if the screen is positive. Now, when you look at ultrasound, we should see that should not be used for the diagnosis of PCOS when the gynecological age less than 8, as I told you previously also, because due to the high incidence of multifollicular ovaries in this stage. Transvaginal ultrasound as an approach is preferred if the girl is sexually active. So when you're doing an endovaginal ultrasound, a transducer with the frequency bandwidth that includes 8 megahertz, then the threshold for polycystic ovarian morphology should be either ovary, a follicle number per ovary of more than 20, and an ovarian volume of more than 10 ml, ensuring that there is no corpus luteum, cyst, or dominant follicle. If you are using a machine with an older technology where the bandwidth is different, then the threshold for PCOS could be an ovarian volume of more than 10 ml on either ovary. In patients with irregular menstrual cycle and hyperandrogenism, an ovarian ultrasound is not necessary for PCO diagnosis. However, ultrasound will complete the diagnosis. In transabdominal ultrasound, reporting is best focused on ovarian volume. And when you have a volume of more than 10 ml, you can think of PCOS. So clear protocols are recommended for reporting follicular number per ovary and ovarian volume on ultrasound. The minimum reporting standards include make a note of the last menstrual period, transducer bandwidth frequency, what is a scan, it's a transvaginal or transabdominal, total follicular number per ovary measuring around 2 to 9 millimeters, and a 3-dimensional volume of each ovary. Also make it a point on reporting the endometrial thickness and appearance, as you can also screen for endometrial pathology. Other ovarian and uterine pathology as well can be assessed, like ovarian cyst, corpus luteum, look for dominant follicles, etc. So there is a need for training in carefully and meticulously counting the follicles per ovary to improve the reporting. So when in a nutshell, enlarged ovaries, hyperechogenic stroma, a peripheral array of microcysts of 2 to 6 millimeters, more than 10 in the old, more than 20 in the latest criteria, ovarian volume of again more than 10 ml with increased porosity index is a diagnosis of PCOS on ultrasound. Biochemical alterations which you can see, normally the FSH will be normal, but there is an elevation of LH. Testosterone is increased and SHBG is decreased. DHEA can be normal or increased, androstenedione is increased. Again, prolactin and fasting insulin is less than 4.5. Prolactin and insulin can be normal or increased. And 1/3 of adolescents with PCOS will meet the criteria for metabolic syndrome. So diagnostic criteria for metabolic syndrome in adolescents, they have to meet 3 of the 5 criteria. That is, blood glucose of more than 100 milligrams per deciliter, HDL level of less than 40, triglycerides more than 110, waist circumference of more than 90th percentile for the age and sex, blood pressure again more than 90th percentile for age and sex, increased level of HDL, and high density lipoprotein cholesterol. So when you come to the treatment of PCOS in adolescents, the role of medications come last. The first and the most important thing will be lifestyle. Lifestyle modification, change in diet, change in your sedentary behavior, include exercise in your lifestyle and behavior strategies, because weight gain is the number one concern expressed by many of the young women with PCOS. And when you have obesity, it may induce PCOS by worsening the features. So what exercise do we normally suggest? In adolescents, at least 60 minutes of moderate to vigorous intensive physical activity per day, including those that strengthen muscles and bones at least 3 times weekly. Activity to be performed in at least 10-minute bouts or around 1,000 steps, aiming to achieve at least 30 minutes daily. So physical activity can include leisure time physical activity, exercises such as walking, cycling, occupational work, household chores, games, sports, or planned exercise in the context of daily family and community activities. When you say this, daily around 10,000 steps is ideal, including structured physical activity of around 3,000 steps. So structuring of recommended activities is needed to consider women and families' routine as well as cultural preferences. Now, realistic physical activity or SMART, that is specific, measurable, achievable, relevant, time-limited goals, could include 10-minute bouts of progressively increasing physical activity, 5% a week, 5% weekly increase up to and above the recommendations. Diet is calories of around 130 grams per day. Snacks and meals should be taken 3 times a day. Total calories.
2 minutes, please, sir. 2 minutes, please. Thank you.
Yeah, total calories should be around 1,500 to 1,600. Break shots should be taken within 2 hours of waking up, because during sleep, body is in a fasting state where there is poor glucose or insulin metabolism. If prolonged, there will be a poor metabolism of glucose and cause weight gain. So breakfast should never be skipped. Avoid refined carbohydrates and sugars in processed foods. An increased intake of omega fatty acid is good. Moderate physical activity again is essential to reduce weight and to resume normal expenses. Cigarette smoking should be abandoned if it is there. And what about medicines? There are only 2 medicines which we can use in adolescence. One is the use of OCPs. The other one is metformin. Now, when you do give OCPs, that is those with ethinyl estradiol and cyproterone acetate should not be used as the first line of therapy because of the potential higher risk, like including deep vein thrombosis. So risk is higher with COCPs containing ethinyl estradiol, gestodine, desogestrel, cyproterone acetate, or drosypyrinone when compared to COCPs containing 30 micrograms of ethinyl estradiol and levonorgestrel, norethistron, or norgestimate. So low-risk COCP preparation should be recommended as first-line therapy. When you give it in combination with metformin, it is for when you have in adolescents who have PCOS and a BMI of more than 25 kg per meter square. So COCP in combination with metformin leads to mild GI side effects, which needs to be discussed. As we know, insulin is a biguanide which lowers blood glucose by inhibiting hepatic intake of glucose, and dose is around 500 milligram TID. It reduces hirsutism by reducing the insulin resistance. So metformin, in addition to lifestyle interventions, could be considered. You can use up to 1,500 to 1,700 milligram per day, and was associated with an improvement in BMI when compared to OCPs alone. So the use of OCPs alone with cosmetic therapy for at least 6 months is recommended before you try anything else. So anti-androgens could be considered as a treatment for hirsutism or androgen-related alopecia. The reported side effects will be, again, GI disturbances. Now, anti-androgen pharmacological agents, where COCPs are contraindicated or poorly tolerated in the presence of other forms of contraception, anti-androgen could be considered. Now, what are the anti-androgens? Again, you have cyproterone acetate, which blocks the hormone action at the receptor level. It decreases 5-alpha reductase activity, induces hepatic enzyme, and increases the metabolic clearance of androgen, given in a dose of 50 to 100 milligrams for 10 days from day 5 of the cycle, or in combination with estrogen. Flutamide, it's a non-steroidal anti-androgen. It blocks the androgen at the receptor site. You give it 250 milligram daily for 6 months, but not used because of hepatic toxicity. Spironolactone, it is an aldosterone diuretic, inhibits androgen synthesis from ovary and adrenal. Finasteride inhibits 5-alpha reductase. You can also give ketoconazole or cimetidine. Anti-obesity medications, in addition to lifestyle, could be considered for the management of obesity in adults, but not generally recommended in adolescents. So orlistat is one anti-obesity drug available. Sibutramide is again available for morbid obesity, bariatric surgery. Mechanical methods to remove hair, temporary methods like shaving, waxing, creams, permanent methods like electrolysis and laser. The surgical method, again, not in adolescents. Inositol, in any form, should be currently be considered as an experimental therapy in PCOS with evidence suggesting that it is beneficial, but there was not much literature available. Use of GnRH or luproyl acetate 3.75 milligram every 28 days decreases the hirsutism, but osteoporosis is an undesirable side effect in young girls, even with add-back therapy, so not used. So in a nutshell, when you have a woman with PCO, adolescent girl with PCOS, the main recommendation would be diet, exercise, and OC pills along with or without metformin. Thank you.
Can you stop it? Okay. Niranjan?
Yes, Dr. Raghavendra, very nicely done. Now I call upon Dr. Devika Madam. Dr. Devika Gunashala is a managing partner of the Gunashala Surgical and Maternity Hospital, Bangalore. She has got many presentations at national and international conferences, 17 to be precise in the international journal and 19 in national journal. She also has an institute of in vitro maturation of immature oocytes, first in Karnataka to start an in-house PGS program. More than 100 pregnancies have been produced by this technology at the Gunashala Fertility Center. She has also the Gunashala Institute of Research in Cancer and Fertility for preservation of fertility in such patients. And I want to tell you, it is a charitable, it is free of charge. And until now, 433 men and 39 women have cryopreserved their semen samples, embryos, and ovarian tissue. A very noble cause she is doing. She has her own Institute of Academic Excellence in Healthcare, that is IAEHC, which imparts training to young gynecologists in the field of infertility and obstetric ultrasound. And she has conducted, along with JSS University, an MSc Embryology course where more than 43 students have taken this knowledge and have gone across the globe to further teach. These are the droplets in the ocean of academics which Dr. Devika Gunashala has done. I call upon Dr. Devika to start her presentation. Thank you so much.
Thank you very much, Dr. Chavan, and I'd like to thank Dr. Sanjeeva Reddy for having given me this opportunity to present this talk in the very esteemed TAPI SR. I also would like to thank Vijay Raghavan and Merck for having given me this opportunity. I would like to say that when I actually started, when Dr. Sanjeev Reddy sir actually talked to me about doing this presentation, I immediately agreed because I felt there were so many lacunae in my knowledge about hyperinsulinemia and PCO. And I thank you very much for giving me this opportunity because it was a good reading experience, and I have learned a lot. But I hope I can effectively communicate this very complicated topic to the audience, and I hope you will benefit. So next. So I just would like to go on to my next slide. Yes. Now, 30% of all infertility is associated with anovulation, and 85 to 90% of this is attributed to PCO. Now, 21 to 59% of women in the reproductive age demonstrate an ultrasound picture of polycystic ovaries, and about 30 to 50% have clinical or biochemical signs of anovulation and androgen excess. And this slide and the next has been given to me by my very good friend, Dr. Madhuri, and I thank her for that. The prevalence in the South Asian population is about 50%, and in the Caucasian population varies between 20 to 33%, and that is PCO, that is ultrasound appearance of PCO, and 5 to 25% of PCOS. Now, as we all know, it's a very complex clinical syndrome, and there are the obvious signs of PCO, which we all have come across. It's unpredictable, irregular periods, heavy periods sometimes, prolonged bleeding, acne, oily skin, hirsutism, acanthosis nigricans, obesity leading to a lot of decreased self-esteem and depression, which Dr. Prasad has already talked to us about. The hidden symptoms would be increased blood sugars. People can be pre-diabetic or may have diabetes mellitus, hypertension, increased cholesterol levels, increased risk of cancer, sleep apnea, definitely infertility and miscarriage. Now, Bergen and colleagues in 1980 made a few statements about PCO and the complexity of it. And they said that there is an increased basal and glucose-stimulated insulin levels. Hyperinsulinemia and insulin resistance was seen. Impaired glucose tolerance with dyslipidemia also formed a feature of PCOS. Hypertension and impaired fibrinolysis, that means a higher tendency to producing clots. And this was a disorder exclusively related to young women, which may have health implications later on in life. Now, we all know the PCO triad, chronic anovulation, hyperandrogenism, and PCO. Can we have the next one? Yeah, and I just would like to say that it is, again, going back into this, it is a complex clinical syndrome. Again, I've taken this slide from Dr. Madhuri Patil. It's a very good slide because it shows a huge interaction between the genetic interplay and the multi-gene environmental interaction and environmental and lifestyle, which is all contributing to hormonal changes with obesity and quite a large proportion, almost about 70 to 80% of women who have PCO are obese, which then produce the three main problems: increased androgens, increased insulin, and ovarian follicular dysgenesis with all its associated hormonal problems. Increasing androgens will produce hirsutism, acne, and alopecia. Increased insulin with its resultant hyperinsulinemia will produce type 2 diabetes, metabolic syndrome, and cardiovascular risk. And of course, the underlying are all the psychosocial issues: body image, self-esteem, depression, and anxiety. Now, we are talking about hyperinsulinemia and insulin resistance in this talk, and this seems to be the culprit in PCO, producing a host of symptoms. Insulin resistance is defined as the decreased ability of insulin to stimulate glucose transport into cells, or a decreased glucose response to a given amount of insulin. And the resultant hyperinsulinemia is a compensatory response to this target tissue resistance. Now, there's always a discussion as to which came first. Was it the insulin resistance and hyperinsulinemia or hyperandrogenemia? So now, having gone through a lot of literature, there are enough arguments to talk about both, to say that, it could be insulin resistance or it could be hyperandrogenemia. But from whatever I have read, I feel that it is unlikely that it is a result of hyperandrogenemia, and these may be the reasons for it. One is, if you have a bilateral oophorectomy, so there are no ovarian androgens coming in, you still have hyperinsulinemia. Suppression with GnRH analogs and thereby suppress androgen production, insulinemia is still there. In prepubertal girls with acanthosis nigricans, which is shall we say, a symptom of hyperinsulinemia, you see this in prepubertal girls with hyperinsulinemia, even if the androgens have not started to increase, and testosterone, androgens, etc., increase only at a later, many years afterwards. And normal men have 10 to 30-fold increase in androgen levels compared to women with no hyperinsulinemia. So insulin resistance and hyperinsulinemia seem to be a universal feature of PCOS. Now, how does that produce the first of the triad of hyperandrogenism? So when you have increased insulin, it works via the receptors and increases ovarian and adrenal androgen biosynthesis. Increased insulin also produces an increased LH-induced androgen production by TOG cells, and it also works on the HPO axis, thereby increasing the amount of LH coming out from the pituitary. It also upregulates the IGF-1 receptors in the TOG cells, and thereby producing an increased androgen in the ovarian environment. There is also suppression of IGF binding protein 1 in the liver, and this increases the intrafollicular free IGF-1. It decreases the sex hormone binding globulin production in the liver again, which then again results in an increased free androgen. Now, a small word about IGF-1, which increases in the follicular fluid. It is a potent stimulator of LH-induced androgen synthesis and makes the TOG cells more sensitive to the LH that is coming in. Next. Now, what about ovarian dysfunction? Now, so again, we have hyperinsulinemia in the center. It has an effect on the hypothalamo-pituitary-ovarian axis and thereby produces increased LH, which acts on the ovarian theca cells and produces, as well as the granulosa cells. In the theca cells, it increases the androgen production. In the granulosa cells, it produces premature terminal differentiation of the granulosa cells in small follicles. Hyperinsulinemia also amplifies cytochrome P450C17 alpha activity in the theca cells. Now, what does this cytochrome do? The cytochrome P450C17 alpha is a very important substance in the pathway of progesterone to testosterone conversion. So from progesterone, we have the 17-hydroxyprogesterone, etc., goes down to producing androstenedione and then finally testosterone. So that plays a very important part in that pathway. So it amplifies this, and hence there is an increased androgen production and virilization. And there's an increased E2 as well, which again works on the HPOA axis. Now coming to the left side of your screen, go back please. Left side of your left side of your screen, you have granulosa cells of small follicles. Hyperinsulinemia amplifies the premature responsiveness to LH. All these together produce a premature terminal differentiation of granulosa cells in the small follicles, producing an early arrest of follicular growth and hence an ovulation. Now, what about the ovarian morphology, which is the third aspect of PCO? Now, we all know that a lot of the time PCOs have a very high AMH, and AMH inhibits primordial follicular initiation. It decreases FSH sensitivity of the follicles, and there's a decreased aromatase expression, which thereby prevents the conversion of androgens to estrogens. On the other right hand of your screen, you have again hyperinsulinemia acting again through its increased LH and hyperandrogenemia, and the whole thing together produces anovulation. And along with this, there is arrest of follicular growth. So you have crops of follicles coming up, which are then prematurely getting differentiated, and hence there is a follicular arrest and then produces accumulation of follicles, thereby contributing to the PCO morphology. Now, what about hyperinsulinemia and implantation disorder that we see in PCO? Because a lot of PCOs do have miscarriages and they're unable to get pregnant. So now there is a substance called as glycodelin, whose main function is to produce endometrial maturation as well as decrease the endometrial immune response to the embryo. So this hyperinsulinemia decreases this glycodelin, which thereby decreases the endometrial maturation, and it also produces a decreased inhibition. That means there is a more active endometrial immune response, so against the embryo. So it decreases the inhibition of endometrial immune response to the embryo. On the other side, you have a hyperinsulinemia. We've talked about it decreasing the IGF binding protein 1 in the liver, and IGF binding protein 1 again it plays a very important role in facilitating adhesion between the feto-maternal interface. And what happens when the IGF-1 binding protein 1 decreases? There's a decreased adhesion at the feto-maternal interface in the peri-implantation period. Comparative study in PCOS with metformin versus placebo showed that that in the metformin group in the luteal phase, glycodelin increased by 3 to 4-fold. There was an increased IGF-BP1, increased vascular penetration, and a 20% decrease of the resistance index in the spiral arteries. Next. Now, we come to a very complicated topic of obesity. Obesity, again, has many ramifications with when it deals with insulin, inflammatory metabolites, etc. Now, adipose tissue is not just sitting there making us look fat, but it is an endocrine and a paracrine organ. It produces what are called as adipokines, which act as hormones, and also produces plenty of pro-inflammatory factors. And these abnormal levels cause inflammation and abnormal cell metabolism and function. Now, leptin is a satiety hormone. Now, what do adipokines are? It's a collective name for, shall we say, leptin, adiponectin, ghrelin, inflammatory cytokines like TNF-alpha, IL-6, increase, Now, what I want to tell you is that leptin is a satiety hormone. Increased leptin levels produce satiety. That means when you have increased leptin levels, it goes to your brain and it tells you that, look, you're eaten enough and your hunger is being satisfied, so you stop eating. When you have decreased leptin levels, you feel hungry and you want to eat. In many PCO patients with obesity, this system is faulty, and despite increased leptin concentrations, secondary to the increased adipose tissue, the efficacy of leptin decreases, leading to leptin resistance. Now, adipose tissue is of two types. We all know there's a subcutaneous adipose tissue and a visceral adipose tissue. And the visceral adipose tissue is the one that seems to be contributing to all these changes. And this is a kind of a diagrammatic representation. So you have the visceral adipose tissue, which are these really huge fat cells, which produce an increased leptin resistance, increase in TNF-alpha, IL-6, free fatty acids, androgens, and estrogens, thereby resulting in insulin resistance and hyperinsulinemia. And because of this leptin and obesity phenomenon, PCO is now again being considered as a condition that has been that is pro-inflammatory. It is there because of a lot of pro-inflammatory factors. So we've gone through this whole thing again about early follicular atresia, increased follicular apoptosis, there is stromal deserialization and decreased endometrial receptivity because of obesity and the leptin, as well as hyperinsulinemia, and as well as in the liver, where it produces a decreased amount of SHBG and the IGF binding protein. Next. So what are the goals of treatment of hyperinsulinemia? Is basically to reduce the circulating androgens and improve reproductive function and fertility, ameliorate PCOS-associated complications due to hyperinsulinemic insulin resistance, such as glucose intolerance, dyslipidemia, hypertension, and atherogenesis, and enhance weight loss. It's also very interesting that when I was reading about obesity, I did find that women who are obese, PCO women who are obese, have a higher tendency to formation of clots and also atherogenesis in their carotid arteries, and at a higher risk of strokes in their mid-40s and 50s. So how do we tackle this? So the treatment options would be lifestyle modification, pharmacotherapy, and surgery. Now, coming to lifestyle modification, Dr. Prasad has gone into detail. It is just a repetition. 500 to 1,000 kilocal per day decrease from the usual dietary intake should lead to 1 to 2 pound weight loss per week. He has already talked to us about 1,000 to 1,200 calorie per day diet. Even a 5% decrease in the body weight will produce significant changes in the quality of the oocytes and in the overall well-being of the patient. Physical activity, we say at least 150 minutes weekly of moderate activity such as walking. Behavioral modification, psychological, behavioral, and stress management. Now, pharmacotherapy. So the aim of pharmacotherapy is to improve peripheral insulin sensitivity and thereby indirectly reduce insulin secretion, that is insulin sensitizing drugs. Dr. Prasad again has done a lot of my work, especially in this area over here. So he's talked about metformin, which is a biguanide, and metformin, I'm not going to repeat the whole thing. Metformin combined with a low calorie diet seems to have produced weight loss. Next. Metformin along with weight loss can be recommended in adult women with PCOS with a BMI of more than 25 for management of weight and metabolic outcomes. In adolescents, we've already heard Dr. Prasad. It's also used in the high-risk groups such as women who have diabetic risk factors and impaired glucose tolerance or high ethnic groups. This is all recommendation from the HRA 2018. It's a guideline on PCO. The gastrointestinal side effects are present and are generally dose dependent and are self-limiting, starting with a 500 milligram dose and 1 to 2 weekly increments. It seems to be safe, but you may have low vitamin B12. Now, what about inositol? Inositol is involved in cellular glucose uptake and glucose glycogen synthesis. At the ovarian level, it is involved both in FSH signaling and insulin-mediated androgen production. But there is insufficient evidence for an effect of inositols on ovarian reserve markers and to support their use as pre-treatment before IVF ICSI in women with PCO. And what about the other drugs to weight loss? To produce weight loss, you have phentermine topiramate and lorcaserin, liraglutide and semaglutide. So this is a very good article in JAMA, which had come out in 2016 by Kera et al., which actually said that on the y-axis you can see that phentermine topiramate is the one that produces the best weight loss in women, and on the y-axis it shows that the y-axis basically shows the adverse event outcome, and so higher scores reflect the lower probability of discontinuation due to adverse events. All of these do have adverse events with hepatotoxicity, etc. So it must be taken under a lot of supervision from somebody who knows what they're doing. Now, COC, that is combined OC pills, alone should be recommended in adult women and adolescents with PCOS for the management of hyperandrogenism and irregular menstrual cycles. Dr. Prasad again has elaborated very nicely on this. Ethinyl estradiol precipitated acetate should not be the first line. COC along with metformin can be used in women with PCOS for management of metabolic features where COC and life size do not achieve the desired goals. In adolescents with POC and BMI of greater than 25 kg per meter square, where lifestyle and COP did not achieve the desired goals. And with anti-androgens should only be considered in PCOS to treat hirsutism and treatment of androgen-related alopecia, and must be used with effective contraception to avoid male fetal undervirilization. Now, I would like to talk about bariatric surgery, which was the third treatment option. We have some experience on this, and we had published this article in the Indian Journal of Surgery as recently as in March this year. It was a single center retrospective cohort study comprising of 28 women, PCOS of 17 and without PCO 11 with a history of infertility who underwent bariatric surgery for morbid obesity. I'm just giving you the gist of this whole study. The mean of total pregnancy rate was 64.28%. And I want to say that majority of the women got pregnant with no treatment at all. Soon after their weight loss, they became pregnant. There was only one woman who had to go on to getting pregnancy with an IVF cycle and one with an IUI. But the rest of them got pregnant spontaneously. At 1 year of follow-up, the mean BMI among all the study participants decreased from 49.11 pre-surgery to 29.33 post-surgery. Similarly, the prevalence of impaired OGTT reduced from 42 to 3.57 among the study groups. AMH levels were in the normal range for both groups after surgery, but were not statistically different. The fasting insulin level, I'd like to kind of, bring this to your notice. This mean serum insulin level for PCOS group reduced from 26 plus or minus 15 before surgery to 9 plus or minus 3 after surgery. It did reduce in the non-PCO group as well. And the result for the PCO group was statistically significant. And in the postprandial serum levels, the mean serum level for the PCOS group.
3 minutes to go, madam.
Pardon?
2 minutes to go. Sorry, 2 minutes to go.
Yes, I finished. This is the next slide and that's the last one. So the mean serum level for the PCOS group reduced from 138 plus or minus 92 before surgery to 12 plus or minus 10 after surgery. So this was also a statistically significant difference. Now, in conclusion, insulin resistance and consequent hyperinsulinemia is a complex metabolic phenomenon and is an integral part of PCO. Nutritional balance is important for middle-aged women to prevent diabetes mellitus, hypertension, and hypercholesterolemia. It's not hypo. Sorry for that mistake. Young adults, it is important for young adults because it increases the fecundity. The usage of insulin sensitizers only is not enough. There is no clear data showing that metformin alone improves the pregnancy rates or decreases pregnancy loss. Hence, insulin sensitivity agent plus lifestyle changes may increase pregnancy outcomes and pregnancy rates. So thank you very much to all of you for giving me this opportunity to present my talk. Thank you very much.
Thank you, madam. Wonderful presentation. You are absolutely on time, and I'm amazed. There are many questions which have come, but I will get back to you soon.
Sure.
Thank you, madam, for that wonderful presentation.
Thank you.
Well, now I would like to invite the young and dynamic AMOG's chairperson of Endocrinology Committee, and we have Dr. Pratik Thambe, who is an ART consultant, a gynae endoscopist. He has taken wonderful degrees and fellowship from France, Belgium, London, Singapore, Brussels, training in assisted reproduction in Brussels, advanced laparoscopic course. He has been in positions of various committees of MOGS, of AMOGS, of IAG, of MSR, AMC, and ICOG. And I would request him also to start his presentation. He is also a recipient of many awards, namely 15 MOGS and 7 Foxy prizes. And he has edited 10 books, 3 Foxy focuses, 11 key practice points, contributed over 50 chapters, invited faculty at 600 plus conferences, has himself organized 350 plus CMEs, and he has been editor of newsletters, conclaves, and he was also the convener of Foxy Endometriosis Vision. So I welcome Dr. Pratik Thambe to start his presentation. Thank you.
Thank you, Dr. Niranjan Chavan. At the outset, let me express my gratitude to Dr. Sanjeeva Reddy and to Merck for giving us this platform. Now, most of my work has already been done by the preceding 2 speakers, so I will not bore you for too long. This is going to be a very short, focused, and practical presentation. I will try and keep theory to a minimum. I'm here to talk to you about hirsutism and PCOS. Once upon a time, the famous English author Somerset Maugham said, and I quote, "It is an illusion that youth is happy, an illusion of those who have lost it, but the young know that they are wretched." I'm sure he wasn't talking about PCOS and hirsutism, but strangely, I find that it's very much applicable to the subject that we are going to tackle today. To start with, it's quite well known that this is a disease of the modern age. WHO criteria statistics from 2012 say that it affects more than 100 million women worldwide. I'm pretty sure that now in 2020, this figure has maybe doubled or at least tripled, considering how much obesity and PCOS we are dealing with on a daily basis. The global prevalence can be as high as 26%, depending on which population you are looking at. It's much higher in countries where obesity and type 2 DM are more common. And strangely enough, even in a country like India, which is a country of great diversity, and sometimes we have very poor socioeconomic status in many of the regions of India, the incidence of adolescent PCOS can be as high as 1 in 3. We know how the criteria for PCOS have evolved. I'm not going to bore you by reading out each and every single iteration of how these criteria have evolved, but I just want to put this slide up because I want to point out something very important to you. If you look at the NIH criteria of 1990, the Rotterdam criteria of 2003, Androgen Access Society criteria of 2006, the first criterion listed in all of these is always clinical or biochemical hyperandrogenemia/hyperandrogenism, and that is the topic that we are going to discuss today. We also have a much more recent reference, which is the ESHRE ASRM PCOS guideline, which was published in August of 2018. This is again freely available on the internet, and most of the audience would be aware of this. This is not something which is new. What is unfortunate is that many of us don't take these particular guideline into account while we are formulating our treatment protocols. And to look at treatment protocols in India, when Dr. Nandita Palshetkar was the president of Foxy last year, we did a pioneering PCOS protocols for practice conclave. This was conducted in Hyderabad in March of 2019. And at the subsequent managing committee meeting in Hyderabad in April, we released this. This was organized through the Foxy Endocrinology and Infertility Committees. Dr. Asha Bakshi, you can see in the picture, is the committee chair for infertility, and I was the committee chair for endocrinology at that point of time. So many of the things which we discussed are something which I would like to talk about at length today, but I will restrict myself to talking only about the protocols for practice. There was also an at-risk questionnaire and checklist which we developed, and a 7-step guide for counseling based on international PCOS aware group, but that's a topic for another day. So what are the recommended evidence-based protocols for practice? We are all aware that the pathophysiology of PCOS for almost 2 decades, we have been aware that the central tenet is insulin resistance and hyperinsulinemia. These concepts have been very well covered by both the preceding speakers. So I'm not going to sit and reinvent the wheel and explain the same thing all over again. We are here primarily to focus on the first branch, which you see on the left, which is because of excess of androgens, both actual excess as well as virtual excess, and we'll come to that in just a couple of slides. You have hyperandrogenemia, which is increased blood levels of male hormones, and hyperandrogenism, which is the consequences like acne, hirsutism, and alopecia, which you see in young women suffering from PCOS. What is this functional hyperandrogenism? This is a concept which all of us need to be aware of. We are all aware of the age-old Spiroff model of two-cell to gonadotropin theory. The only point which is relevant to today's discussion is that because of hyperinsulinemia, which is increase in insulin levels as well as poor function of insulin, there is an increase of secondary mediators like insulin-like growth factor, and both of these potentiated with an exaggerated LH and a prolonged LH response during the menstrual cycle. You have an excessive generation of androstenedione, dehydroepiandrosterone, and the androgen precursors, which all of us are familiar with. As far as clinical presentations or phenotypes are concerned, we have 3 main presentations. One is the classic PCO, which is the obese type. We have the ovulatory PCO, which often may not present to us. It slips under the radar because these women conceive on their own. And you have the non-hyperandrogenic phenotype, which is one of the least common types, and these women often are missed. But the most common is the obese classic PCO, and hyperandrogenism, as you can see, is the most common presentation along with anovulation and infertility in clinical practice. What does the ESHRE guideline have to say about this? Now, as we've seen, in all the iterations of the guidelines, right from 1990, 30 years ago, clinical and biochemical hyperandrogenism is the first criterion which is listed. How is it different in the ESHRE guideline? So what they say, and these are all evidence-based recommendations that they've made, they've said that you need to look at calculated free testosterone, the free androgen index, or the calculated bioavailable testosterone. If I were to translate this into simple English, they would say that we need to use more advanced tests than are available widely in India today. The classic tests which you and I use are either ELISA or the older radio immunoassay in some of the smaller towns and villages. But what is now recommended is that you use LCMS or liquid chromatography and mass spectrometry. Just as an aside, I have a very good friend who is a pathologist and he runs an ISO accredited lab in the city of Mumbai. And I asked him what would be the cost of doing an LCMS testosterone assay and how could I pass that on to my patients? Is there any benefit? He said, yes, they are definitely more accurate and they are more sensitive and specific as compared to the ELISA test which we use. But unfortunately, the machine which does LCMS test itself costs 1 crore, and it is beyond the scope for him at least to buy it in the next 4 to 5 years because the demand simply isn't there. So if this is the situation in a large metro city like Mumbai, I don't know what would be the condition in other areas of India. Your guess is as good as mine. In theory, the guideline is very good that we should be using more sensitive assays, and maybe all the question marks regarding reliability of assays would then go away into the background. But practically, whether we'll be able to implement this in our daily practice in the near future, your guess is as good as mine. The guideline goes on to say that other hormones like DHEAS and androstenedione could be considered as part of the armamentarium if your total and free testosterone are not elevated, but they only provide limited additional information. They also go on to say that if women are already on OC pills for contraception or for any other reason like regularization of menses, ideally you need to give a washout period before you conduct these tests. So in practice, the summary of this entire slide is that we are doing certain biochemical assays to look for testosterone, dihydrotestosterone, androstenedione, and DHEAS. In practice, you will find that there is very rarely a 1:1 correlation. Your testosterone levels may not be raised in patients who have hirsutism. In patients who have hirsutism, if you want to assess response to therapy, these androgen assays are very poor markers and probably should not be used to assess response to therapy. Coming to the clinical hyperandrogenism criteria, these are very well known and they have been summarized again in the guideline by saying that we should use standardized scales like the Ferriman-Galway, and we'll come to that in just 1 or 2 slides. And we should also use the Ludwig score in case we have the rare patient who presents with male pattern alopecia. They go on to say that besides looking at hirsutism and assessing hirsutism and acne, we should also be sensitive enough to be aware that there is a negative psychosocial impact of clinical hyperandrogenism, because many of these young girls especially have a very poor body image and they come with anxiety, depression, and suicidal thoughts because their life revolves around social media. If a young girl does not get 1000 likes on Sunday morning for a picture that she posts on Instagram, that's going to be the end of that particular girl's social media career. So she's going to be in an extensive state of depression. And because of the changing lifestyles that we are now seeing, many of these young girls are coming forward with cosmetic issues for even minor reasons, and they need to be sensitively addressed. The Ferriman-Galway score is something which all of us are familiar with. We've studied it in our first MBBS right from our physiology days. This slide is just here to complete the entire discussion that we are talking about. There are 9 different areas that we look at, and this is the scoring chart which is used by dermatologists. And the idea behind this chart is the patient can assess herself on a fixed day every month and score herself and assess whether the therapy, whichever she is being given right now, which she's taking, is effective enough or not. Coming to the management algorithms, I think the first part of this has been tackled extensively by both Dr. Aghavendra as well as Dr. Devika Gunashila. And you know that caloric restricted diets, lifestyle modification, at least 30 minutes of vigorous exercise or 150 minutes per week are what are recommended. We will focus more on the pharmacological management because most of the times weight loss, lifestyle modification, and exercise may not help all that much as far as hirsutism and acne are concerned. They may help with irregular cycles. They will definitely help with a little bit of oligo and anovulation, but hirsutism almost always requires pharmacotherapy. And the pharmacotherapy that we usually are used to administering for these women are combined oral contraceptive pills. And again, the guideline says very clearly that for adult women, the COCP alone is the first choice in the management of hyperandrogenism. In young women who are adolescents and they have a clear diagnosis of PCOS, again, COCP alone should be considered. In adolescents who are at risk but not yet proven to be diagnosed with PCOS, again, COCP could be considered. Now, this is the theory. I don't know how much in practice for a young school-going or college-going girl, you could prescribe an OC pill for say 6 months, 9 months, 12 months, which is roughly the duration of treatment required to treat hirsutism. It's an open question. Whether the patient herself will accept it, whether the mother and the parents will accept it, it's a question mark. But with sensitive counseling and reinforcement periodically, probably you could prescribe these and get them to accept it because they are very effective in the treatment of hirsutism. The $1,000,000 question. There is a new drug. It's not really new. It's been around for about 3 or 4 years now, and it's available to all of us. Is drospirenone better than the age-old drug, which is cyproterone, which we have been using since our undergraduate and postgraduate days? Specifically, the ESHRE guideline says that there is no recommendation for one particular formulation of progestin over the other. But we have some Indian data which shows that the age-old drug cyproterone works much better than both drospirenone and desogestrel. This is a study from Bhattacharya which looked at modified Ferriman-Galway scores. You can see the first graph is of cyproterone, which works much better. The free androgen index also was significantly better with cyproterone. If you gave it for about 12 cycles, depending on different areas of the body, the best results were seen on the face and the chest areas. And in patients even who had severe hirsutism, over 4 years, they found that cyproterone worked excellently. And if you need any further recommendations, the best part is that even after stoppage of the drug, say you're worried, your patient expresses concern, doctor, should I be taking this continuously for more than 6 months, 1 year, and so on and so forth. I've read somewhere, Dr. Google has told me that I may be prone for breast cancer later on in life, or I may land up with deep vein thrombosis. Is this safe to take? So for these patients, you can give a break after maybe 12 cycles and then restart after a break of another 3 to 4 months. It's been found that in the intervening period of up to 4 to 6 months, there is continued anti-androgenic activity, even though she is not actually consuming the pill. What about insulin sensitizers? This has been tackled quite well by the previous speaker, so I'm not going to talk much about metformin. I will address the question of whether the newer inositol groups are available and whether they should be prescribed. The ESHRE guideline says that at present, inositols have very little evidence to recommend them and they should be considered as experimental therapy. But if you look at this meta-analysis published in January of 2018, there were 10 trials involving nearly 600 patients. And in all of these, you can see the forest plots are clearly favoring the administration of myoinositol as compared to placebo. There's also a significant effect on insulin resistance as well, and probably it is through this that we are seeing the reduction in the Ferriman-Galway scores. There's also another meta-analysis published in 2017. This is 9 trials involving a little more than 500 patients. Again, all the forest plots clearly in favor of myoinositol. And that's the conclusion there. It not only improves the metabolic profile, but it also reduces hyperandrogenism, reduces acne and hirsutism scores. The last part of the talk is something which we always think about, but we don't often address. And when do we shift to anti-androgen therapy, which we are not so frequently prescribing? This is a simple flowchart that we've come up with. And when do you consider second-line anti-androgens? If you have 6 months or more of first-line therapy, but your patient still looks like that, if you have androgen-related alopecia, then these patients don't often respond to simple drugs. They need second-line management. But it's our duty to counsel our patients that these drugs are not safe in first trimester of pregnancy. They will need to use barrier contraception as well because they are not contraceptives. And you need to counsel your patient, have a multidisciplinary approach, refer them to a dermatologist or to somebody who is an expert like an endocrinologist in dealing with these patients. Spironolactone, finasteride, and flutamide are the common agents that are prescribed. It's beyond the scope of today's discussion to talk about these in detail, but there is a meta-analysis which was published by Cochrane in 2015, 157 studies, more than 10,000 women, and they said that flutamide, spironolactone were significantly better than cyproterone and desogestrel. You can see the mean difference scores there, and they highly recommend these drugs, but assuming the proper counseling and the caveats are there in place. So to conclude, ladies and gentlemen, PCOS has reached epidemic proportions worldwide. We've talked about the phenotypic classification, the diagnostic criteria, how they have evolved. We looked at modern guidelines and algorithms. As we said, weight loss and dietary modifications may help to a limited extent, but COCs form the mainstay of treatment, including cyproterone and drospirenone. For Indian patients, somehow the old drug cyproterone seems to work better as compared to drospirenone as far as hirsutism is concerned. Second line drugs, anti-androgens, should be reserved for somebody who's an expert like a dermatologist or an endocrinologist. And remember that insulin sensitizer is something which we prescribe left, right, and center. They may be of limited benefit in these patients, but definitely they are of some proven efficacy, even though the guidelines currently do not clearly endorse their prescription. Remember, it's a long-term treatment. It takes 6, 9, sometimes 12 months. Appropriate counseling is essential, and multidisciplinary care should be the order of the day. I'll leave you with one statement, which I'm very fond of saying to my own patients who present with cosmetic issues, that a fit and healthy body is the best fashion statement. It's not the amount of hair you have in your face or the shape of your body or whatever. Remember that you need to be fit and you need to be healthy, have a positive body image, and be confident. Thank you so much for a patient hearing. Thank you, Dr. Sanjeeva Reddy, for the opportunity.
Thank you, Dr. Pratik Tambe. It was an excellent lecture with quotes, and you have given justice to Hirsutism and PCOS. So I would come back to you now. I request now Dr. Prasad to be online, Dr.
Yes,
Devika Gunashala, Madam, and Pratik. There are many viewers who have logged in and have also asked questions. So we will go one by one as per the topic. So the first topic was today presented by Dr. Raghavendra Prasad, Adolescents and PCOS. So there are a few questions, sir. I would like to ask you, how long metformin should be taken in adolescent PCOS patients?
Yeah, basically with all the studies available to us in the literature, it shows that metformin along with your dietary modifications and everything can be used for a maximum of up to 6 months. Because all the studies conducted have told that you can, they've used it only up to 6 months. That in adolescents, the studies beyond 6 months is not available.
So what will be the dose, and do we need to do any, investigations before you go ahead with those drugs, or after 3-4 months again you do some investigations?
No, basically we need a baseline evaluation of the hormones. You need to do a liver function test, and then metformin 1500 to 1700 milligram per day in adolescents has been studied and found to be beneficial. So dosage of 500 milligram 3 times a day is acceptable, but the recommended duration of usage is up to 6 months.
Okay. What is the role of diet in such adolescent girls? Do you find any lean PCOS, or they are mostly obese, probably because of their lifestyle or junk food, or hardly doing any outdoor games? Because these girls are usually coming at 12 years, 13 years, 14 years. They are having amenorrhea. So what in your practice do you find them? Are they lean PCOS, or are they obese PCOS?
Obese patients are much easier to treat because you put them on metformin and give them a proper schedule, things usually respond. Lean PCOS are the ones who keep nagging you for quite a long time because the response is not as satisfactory as you want it to be. And many of them, what we have seen is do not even tolerate metformin because they have quite a lot of side effects with metformin. And in a lean PCOS, when I tell you have to restrict your diet or weight loss or exercise, does not actually work. So lean PCOS, the only treatment option I think is, again, when you have a lean PCOS, COCPs tend to work better than putting them on metformin. Metformin as a treatment regimen, I preferably use in severe lean PCOS. Obviously, I will give metformin, but obese PCOS, I would prescribe them on metformin, COCPs, as well as weight loss and dietary modifications.
Thank you, Dr. Prasad. I will get back to you as the questions come. Now I go to Dr. Gunashala. Hello, madam.
Yes, hi.
Your presentation was very nice. Thanks for being here with us.
Thank you.
What tests you will be doing to diagnose hyperinsulinemia?
See, there are no really that very well-defined tests. There is this HOMA-IR and things like that, which we don't do. So we just look at the fasting insulin levels and, if they are raised, and of course we do a glucose tolerance test. But then I don't think there are any well-established tests for insulin resistance which can be used on a regular basis in our practice. There is that HOMA-IR test, that's homeostatic something, metabolic something, test, whatever it is. Anybody else, I do not know. I only use the fasting insulin as a cutoff. And 1 hour postprandial insulin also. And we've taken levels of less than 10 being normal for fasting insulin.
Okay.
And that is a very practical aspect, because doing insulin resistance tests are difficult, and I don't think there's any standardized test that has actually come out. Does anybody else have anything to say? Dr. Tambe, do you know any tests? You've been in that guideline group.
The problem is that you can do these tests, but they don't always reflect what is happening in the patient in front of you. Yeah. So and there's a lot of diurnal variation, plus there's a day-to-day variation also in the results.
And really the cutoffs are also not very well defined. You do not know what exactly is the cutoff. So you have to take an arbitrary value and, otherwise you have to go into these really complex tests.
Then again, it may be the fasting glucose and fasting insulin ratio. It's an old test, but still remains good for calculating the need for metformin for obese individuals.
I see. Okay.
Thank you. I would like to ask you the next question. What diet we should advise in PCOD cases? This is the question asked by Dr. Sonali Somani.
Yeah. See, the thing is that in PCO, the main culprit is the carbohydrate. Because because what happens when you eat a lot of carbohydrate, it gets taken up by the liver. The first passage is to the liver, and in the liver it gets stored as fat. Some of it gets stored as fat, some of it, the insulin acts on the liver, and then, some of it gets pushed to being stored as glycogen, and then the rest of it gets stored as fat. So it is not just a low calorie diet. You have to concentrate on having a diet which is low in carbohydrates. And fat is not really that much of a problem. So so there are a lot of articles as well as videos that have come out talking about what is called as a keto diet. Keto diet is high in protein, low in carbs. And I mean, a keto diet is if you go to a very severe keto diet, then you have hardly any carbs. But then you can actually go on to a diet which is less in carbs, high in protein, and moderate amount of fat. Because moderate amount of fat is okay, because fat then goes off into the lymph system. So it's not really the one that is actually producing the problem. It is the carbohydrates, which is then again producing an insulin spike. And every time the insulin spike happens, then you're again having hyperinsulinemia and insulin resistance. The whole thing, the whole metabolic process again comes into play. So you're looking at a diet with a low carbohydrate intake.
Yeah. Thank you. Thank you, Dr.
Thank you.
Gurushala. Now I would like to go ahead and ask question to Dr. Pratik Tambe. What is the drug of choice for you, metformin or myoinositol?
So according to the theory, metformin works very well and it's an age-old time-tested drug. But in practice, what happens is by the time the patient comes to me, she is very rarely a de novo patient. She's already been to several consultants. She's already taken several months, if not years, of metformin. And there, if you want to give an alternative to your patient, you have to prescribe something like myoinositol. You can't keep prescribing the same thing and expect different results. This is the practical scenario which most of us who are here will face, because we don't get patients who are coming to us for the first time. We get referred patients who have come to us after many years of issues, whether it's infertility, hirsutism, or obesity. Having said that, when you give myoinositol, I've seen a lot of practitioners give very small doses, 500 milligrams, 1 gram. They get very scared for some reason to exceed 1 gram. This is a clear take-home message that everybody has to imbibe, that the recommended dosage of myoinositol is 2 grams to 4 grams per day. And most of our patients are 60 kilos or greater than that. There is no benefit to be gained from small homeopathic doses of 500 milligrams and 1 gram. We are doing the patient a disservice if we don't prescribe it in the right dosage and the right frequency. So 2 grams twice daily or 4 grams once daily is the ideal recommendation for a minimum of 3 months, and you will definitely see results as far as obesity, oligo or anovulation is concerned within a period of 3 to 6 months. If it doesn't work in that time, by all means move to something else.
Thank you, Dr. Pratik. I would like to read one comment by Dr. Sarojini Dev. I congratulate Dr. Sanjeeva Reddy sir for organizing webinars of various topics which are very much useful for day-to-day practice. Speakers are very good. So Dr. Sanjeeva Reddy, you are hearing, and I want to tell the audience that we have got 503 users logged in right now on Sunday afternoon to hear eminent speakers of versatile from all over India, of versatility to be here. I continue with my questions, one more round, and then we will hand over to the next moderator. This is the question to Dr. Prasad. What is the role of N-acetylcysteine and vitamin D and calcium in the use for PCOS? This is Dr. Chandu Gula Suresh Babu.
With the vitamin D, there have been quite a lot of studies telling that PCO women have got, they have demonstrated that supplementation of vitamin D to women with, to people, women with PCOS has brought about an increase in cycle regularity. So vitamin D can be supplemented. N-acetylcysteine, although there are quite old studies regarding N-acetylcysteine, I do not prefer to use them in adolescent per se, because I have not come across studies of usage of N-acetylcysteine in adolescents. Whereas vitamin D is a supplement which even adolescents, it can be given in adolescents also because it is beneficial. What was the other drug, sir, which you had asked about?
Calcium.
Yeah, calcium I don't routinely recommend. I have not come about literature because I think our diet is sufficient in calcium.
Sir, one more question to you. Dr. Shabana Sheikh is asking, intolerance to metformin, what to do in adolescent girls?
Yeah, this is one common problem which we have seen. Most of them, have quite a lot of intolerance to metformin. In such conditions, I normally give them dietary advice, and if they are very much insisting on cycle regularity, then I put them on COCPs for 3 to 4 months and give them a diet plan, so that by the end of 4 months they would have at least reduced some amount of weight. So because unless and until you lose weight in obese PCOS, your cycles will not become regular. So until that time when they lose weight, probably COCPs will help.
Can I just add to this? This is out of my experience with close relatives, etc. We coolly tell them take 500 milligram of metformin twice a day. The amount of problem that I have had with them coming back to me and telling them, I say I can't, deal with it. I have too much of gastrointestinal disturbances, too much of loose stools, running to the bathroom every few minutes. It is simply incredible that metformin, and then they say, it can be tolerated, it's very self-limiting, but how long is it going to take to be self-limiting is another question. So that is one thing. And then they all get very tired. And the third thing is that I think in PCO, especially when you have so much of insulin resistance, I think, diet is the mainstay. Yes, you can talk about exercise. And in people like me, I'm not PCO, I've finished my childbearing and everything else. But then
I think
then so it's not easy. But then making alterations in the diet, that is a little bit more, shall we say, feasible, especially in adolescents, because you can actually tell them not to eat this and not eat that and cut out the junk, and cutting out the junk itself will produce a huge difference. And I think the decrease in the carbohydrates is the most important thing. What do you think, Dr. Prasad?
Ma'am, adolescence, I think, is the right age for us to mold the women as they progress into the early life. If we are able to inculcate into them a healthy lifestyle and a good dietary system into them, probably they will continue that for life. And as they grow older, the problems which they face, the problems of PCOS which they face will definitely come down.
Yeah. It's that adipose tissue in obese PCOS, which is the real culprit. I think so. I do not know.
Second part of the
and see, schools are places where you can form groups and bring them into an exercise and diet form special groups for these people, because possibly group therapy is one, because a parent alone cannot institute diet and exercise. So some kind of support groups and group therapy might help.
Okay, one more question now. This is to Dr. Pratik. Sir, any role of pioglitazone in PCOS, Dr. Haji Arshia Barin?
So there are some research articles which mention two molecules, rosiglitazone and pioglitazone, but specifically their usage in hirsutism has not been studied, and they are not of much clinical benefit. In fact, even the ESHRE guideline does not recommend their clinical use in routine practice.
Okay, now regarding hirsutism, Dr. Pratik, what is the role of doing serum testosterone and dihydroepiandrosterone?
So as I mentioned, the guideline says that while all of us have been doing traditional tests like ELISA and radioimmunoassay, these are not very sensitive or specific. There is a lot of diurnal variation, and the levels that you see may not correlate with the clinical picture in front of you. They may be diametrically opposite, and therefore it is recommended that you switch to the newer LCMS assays. Like we said, LCMS is not widely available in our country as of today. You could do a total and a free testosterone assay, but it may not correlate very well with the clinical picture. And therefore, if the clinical picture warrants you starting anti-androgens, by all means do so, even if your biochemical assays are within normal limits.
Yeah, I would request the others to please mute their mic. Now this is Dr. Sindhu Bhargavi. Dr. Devika Gunashila, this is for you. Should SHBG be done initially and recheck after 6 months? Will it show increase?
I have no experience in this. I don't do SHBG per se. I go more by the fasting insulin, and of course their body habitus and the PCO morphology, AMH levels, the FSH-LH, ratios, which quite often are altered. I don't personally do SHBG, and maybe if somebody else has experience in that, they could answer that question, but I don't do it.
Dr. Prasad, Dr. Pratik, would you like to comment on this?
See, okay, just one thing. You can do hundreds of tests. You can do androstenedione, you can do DHEAS, you can do testosterone, you can do SHBG. You can keep on doing tests for PCO. There are so many million tests that you can do. But how effective is it going to be in your treatment, and how far are you going to, work on it is a question. I mean, if you have somebody who's got, severe, shall we say, hirsutism, like one of the pictures that Dr. Pratik showed, yes, then maybe you want to find out where exactly how high is the testosterone, where is it coming from, and things like that. But in a general obese PCO woman who's got irregular periods, you see a PCO morphology on scan. I think you must tackle PCO in a very practical aspect, because there is no end to it. There are 101 hormonal imbalances that are happening, and I definitely would like to hear our esteemed speakers and Dr. Sanjeev Reddy and everybody else, what is your opinion?
Can I just add to what Madam has said? At the beginning of my talk, I had a couple of slides which I have hidden, which I have not shown in the interests of time. Generally, we assume and we presume that all androgen secreting endocrine issues is equal to PCOS. But that is not the case. PCOS is a diagnosis of exclusion. In rare cases, you may have something like congenital adrenal hyperplasia, you may have androgen secreting tumors, and these can present to you as hirsutism. You will keep thinking that it is PCOS. These are the patients where you need to do androgen levels, testosterone, androstenedione, DHES, SHBG. They will all be off the charts. They will be in multiples of 10 or more if it's a androgen secreting tumor or a congenital adrenal hyperplasia. Don't miss these patients. For all other patients of PCOS, as we said, your androgen levels neither indicate whether you should institute therapy with anti-androgens, nor do they dictate whether the response to the therapy is appropriate. For identifying whether your therapy is appropriate or not, use a simple Ferriman-Galway score, which is done monthly for 6 months or 9 months. And when you find that your therapy is not working, maybe it's time to take a second opinion from an endocrinologist or a cosmetologist.
Thank you, doctors. I think my time has come for your question answer session. It was a wonderful presentation by all three of you. We have innumerable questions still coming on, but we stick to time. And I thank all of you and Dr. Sanjeeva Reddy and Science Integra and Merck to be a part of this program and moderate this session. I hand over the mic to Dr. Sanjeeva Reddy.
Okay.
So I would just like to express my gratitude to the program coordinators for today, Dr. Kamala Selvaraj Madam, Dr. Sanjeeva Reddy, Dr. Vijaya Ganesh. Thank you so much for having us. And we would all of us like to wish Dr. Niranjan Chavan all the very best for his joint treasurer election of IAG. All the very best.
Treasurer's post.
Yes, sir. All the very best, sir.
On behalf of TAP, sir, I thank Dr. Prasad, Dr. Devika, Dr. Pratik Tambi, and Dr. Niranjan Chavan for accepting our request and making this session very interesting. Dr. Niranjan is having some appeal for the participants and faculty also. Please, Niranjan.
Thank you, sir, for giving me this opportunity. I am Dr. Niranjan Chavan. Well, all of you might be knowing me, but some of them might not be knowing, or it could be the other way around also. I did my undergraduation from the prestigious St. GS Medical College in 1985, following which I joined Sion Hospital as a houseman, and for last 28 years I am there. Now I am a professor and unit head since last 11 years. I have also contributed a lot of efforts to Foxy and endoscopy, which I would like to name a few. In endoscopy, I have been a teacher and I have trained more than 500 endoscopists from all over India, as we have the certificate course which is on basic infertility and endoscopic management since 2010, and that is the certificate course of 6 months. In 2018, we have started also advanced courses of endoscopy, and that also we have got training of most of the people coming from nook and corner. So I welcome all of you. You can come to Bombay, because in Mumbai we have a stimulation lab at Sion Hospital. One instrument is of hysteroscopy and another one is of laparoscopy from Sweden and Germany. You get wonderful simulation, and this is the first time in a municipal medical college. I have been also an examiner for MBBS, DNB, CPS, DGO for various universities, and it's my vision that endoscopy should be given to all, and endoscopy for every gynecologist. I would like you to please vote and support me, because I have clinical and administrative and organizational capacity with leadership goals and ability to lead my esteemed organization IAGE, for which I have been a member of 6 years as the managing committee. And this request is for you. Please exercise your right to vote, because voting is very important. People don't vote, and that also is not good for democracy. So from 1st of October, the lines will be open, and please do remember my name Dr. Niranjan Chavan, and vote for me. Thank you so much for a patient hearing. Thank you, sir.
Thank you.
Sanjeeva Reddy, sir, you can start the next session. Thank you so much.
Okay. Thank you. Thank you.
Thank you, sir.
I request Dr. Vijaya, Executive Committee member of TAPISAR, to introduce the next moderator.
Manisha, thank you, sir. It's my pleasure to introduce Ma'am Dr. Nirmala Sadasivam. She did her undergraduation in Keel Park Medical College. Her diploma in OG was also in Keel Park Medical College, and his post-graduation in IOG EGMO. And she finished her MNMS in 2010. She's also got her PhD in Assisted Human Reproduction in 2011, CCMB Hyderabad. He started ART practice in 1994. She's trained under Professor Arif Bangso, NUH Singapore, pioneer in blastocyst extended culture. She's practicing ART in Erode and Coimbatore. Ma'am, I welcome you to moderate the session, ma'am.
Thank you, Dr. Vijaya. Nice words you have uttered on me. Thank you so much. And today's program is parted into three. The second one, which we are going to deal with now, is highlighting you the practical events and points to take home as practically using in your clinical day-to-day issues. So I first call upon Dr. Jyoti Bali. Next slide, please. Slide to introduce Dr. Jyoti.
Second, madam.
Yeah.
1 second.
So she's a director of Baby Soon Fertility and IVF Center and fellow in reproductive medicine. She finished in Bangalore. Ex-consultant and unit head of Fortis Law Femi Hospital, founder secretary of Delhi Gynec Forum and vice president of the same, secretary of Delhi ISAR in 2019 to 20, joint secretary National IMA Women Wing, the recipient of Navashakti Award and 8th National Women Excellence Award. And the stage is for you, Dr. Jyoti. You're welcome for this speech.
All of you, please keep your mics in mute position, please.
At the outset, let me thank Dr. Sanjeeva Reddy for the invite, and I congratulate TAPISAR for having found this topic at the right time. In September is the PCOS Awareness Month, and this particular disease, of course, the previous speakers have enlightened us very well as to the pathophysiology is chicken out of egg or egg out of chicken. It still remains an enigma for most of us and to make the population understand. And I also thank our chairperson, Dr. Nirmala ma'am, for having introduced me. Thank you for the invite. To begin with, I think the topic has been well covered by the previous three speakers, so I will skip the slides of repetition to save time. And the topic given to me is lifestyle management, because this remains an important component of this particular disease, PCOS. Diagnostic criteria, of course, again, I will repeat two of the following. Three criteria required: oligo/anovulation, hyperandrogenism, hirsutism, or less commonly, male pattern alopecia, or biochemical, that is the race-free androgen index or testosterone. Polycystic ovaries present on ultrasound. Two of the three, as per the Rotterdam criteria, is enough to diagnose PCOS. The signs and symptoms have been discussed in the last few three presentations. Now, the global prevalence is 2.2% to 26%, roughly 1 in 15 women worldwide. 36% of women in India are suffering from PCOS. 70% remains undiagnosed, and only 30% comes to diagnosis. Now, we all know that environment and lifestyle factors overlapping on genetic factors predispose to PCOS in adolescents. This is a very important group because catch them young. Modification, behavioral changes, advice, counseling, all is very important in this group. We all know that premature puberty and PCOS, there is excessive adrenal androgen secretion, persistent adrenal androgen secretion, excessive ovarian androgen secretion. All will lead to oligoamenorrhea or hyperandrogenism being a feature there. And of course, the only way, of course, Pratik has mentioned as to how to handle this particular thing, oral contraceptive pills, and of course, lifestyle will remain an important part in these young adolescents. So lifestyle intervention at this point of time will lead to regular cycles, no hirsutism, normal androgen concentrations for these young children. Lifestyle, diet, exercise, and behavioral changes, how to counsel them, how to bring about these changes is important as to how we advise them. So what should be the diet? What should be the exercise? What should be the behavioral changes? And how is behavioral changes important to contain, sustain? Because PCOS, most of them, when they come to the clinic, they ask us, is there a permanent cure to this problem? So explaining the pathophysiology or the genetic basis, that this is a genetic endowment which cannot, one has to live with it and know what it is all about, and how lifestyle remains an important component here is important for every person to know. So 5 to 10% weight loss in 6 months, of course, we are advising to them, but art of counseling comes here as to how to advise. If I tell a patient here in my clinic, lose weight and then we will see. Losing weight advice given just verbally, it will not go a long way. So this requires a lot of counseling as to explaining to them how they are supposed to lose weight, what is the diet they are supposed to take, or how they will exercise. So diet and exercise in this group, endocrine metabolic parameters markedly improve after 4 to 12 weeks of dietary restriction. There is no magic which happens. It is day-to-day based management. SHBG levels rise and free testosterone levels fall by 2-fold. Serum insulin and IGF-1 levels also decrease, associated with a reduction of hirsutism and a return of ovulatory cycles in 30% of women. Energy deficit of 30% or 500 to 750 kilocalories per day. Be prescribed a minimum of 150 minutes per week of moderate physical activity or 75 minutes per week of vigorous intensity cardiovascular exercise be advised. An equivalent combination including muscle strengthening exercise activities or 2 non-consecutive days of the week should be advised. Now, diet was an important thing which was being discussed as to what diet to advise. It is mainly the carbohydrates, which is a factor, as Dr. Gunchila mentioned in her answering right now in the previous session. Studies have cut down on calories, especially in the evening. Why evening is important? That should also be emphasized on, because it is the time when the day is getting over, you will sleep and this will get accumulated. So evening time is important, early meal before sunset. Studies have also shown that a caloric restricted diet may help normalize hormones, induce ovulation and fertility treatments, spread the calories throughout the day by having 5 to 6 small meals rather than having 3 large meals like breakfast, lunch and dinner. It should be smaller meals but different intervals and regular intervals. Favor monosaturated fats. Nuts help fight insulin resistance associated with PCOS. Choose low GI carbs. Reduce cravings as they provide the body with a slow and steady supply of energy. Increase intake of vitamin B, all B2, B3, B5, B6, B12. Ensure a sufficient intake of calcium and vitamin D3. Vitamin D3, of course, we are all deficient in because we don't expose ourselves to enough sunlight. In scenario of infertility, I think we have started giving vitamin B12 and vitamin D3 to all vegetarians. And it's usually it's like epidemic. Vitamin D3 deficiency is an epidemic. Ensure a sufficient, consume foods rich in zinc for acne and obesity. Eat foods that contain chromium. Chromium helps to maintain blood glucose levels. So this is again, just to put it up again, reversing insulin resistance, what to add or increase. Use up your fiber intake. Get moderate sleep and exercise. 8 hours of sleep is important. Drink more water. Try herbs and spices like cinnamon, ginger, turmeric. And even with COVID times, I think we are all using these things to boost our immunity. So this is something which I think has been there in our Indian food forever. Eat the rainbow, have all organic fruits and vegetables, green fruits, green vegetables, fruits, everything to be included. So the rainbow is included in the diet. And soluble fiber helps modulate the release of glucose into the blood during digestion. So generally, health style, lifestyle, this needs to be focused upon and be very sure that the person is counseled well on what to have, what not to have. So this was an interesting one which I came across, 28 March 2019, Cochrane Library. It says that lifestyle intervention may improve the free androgen index, weight and BMI in women with PCOS. One second. We are uncertain of the effect of lifestyle intervention on glucose tolerance. There were no studies that looked at the effect of lifestyle intervention on live birth, miscarriage, or menstrual irregularities. Most studies in this review were of low quality, mainly due to high or unclear risk of bias across most domains and high heterogeneity for the FAI outcome. Now, this Pratik was mentioning about hirsutism from the same article, as he said that we don't apply in our practice. So this particular article from 2018, which has the guidelines from ASRM, ESHRE, put together and easily available on the internet. I think we must look at these guidelines. They are important to write a prescription. Just verbal counseling as to what the person should do in lifestyle modification is a very wide, it's a very varied thing. So how to exactly write a prescription for an individual? It should be individual based and not just a generalized prescription or a counseling that is done. So it says, this particular article of 2018, I found it quite good. It says that healthy eating and regular physical activity should be recommended in all those with PCOS. Lifestyle intervention, diet, exercise, and behavioral strategies should be recommended. 5 to 10% of weight loss in those with excess weight yields. There is no exact cutoff. In terms of infertility, we always tell them that 5% body weight loss, especially around the area of the stomach, especially around the fat tissue in the stomach. Then if that weight loss is advised, the patient might resume her cycles, ovulation might resume on its own. It's an achievable goal which is given. If I just tell a 90 kilo woman that you lose weight and come, she'll never come back to my clinic again. The counseling has to be very practical, that look, if you can't lose weight, lose inches, but follow a balanced diet and an exercise regime. If you can't motivate yourself, then it should be under supervised trainer or a nutritionist or a gym or a dietitian, and you have to achieve this much. And 5% body weight loss is achievable. So the patient also feels very motivated to do it, but just advising weight loss random will not work. So this is important, that only 5 to 10% will do the things. SMART, what is the SMART prescription? It says specific, measurable, achievable, realistic, and timely. Goal setting and self-monitoring. So S is specific and measurable, M is measurable, A is achievable, R is realistic, and T is timely. So it is a SMART prescription, SMART counseling for lifestyle management. Psychological factors need consideration and management to optimize engagement and adherence to lifestyle interventions. Healthy lifestyle and optimal weight management. Now, behavioral intervention. Why behavioral intervention is important? It very clearly says that it is your thought which will create a feeling, then it is your feelings which create a behavior. It is behavior will create thought. So it's a vicious circle. Unless the person is counseled, convinced, and agrees and gets the thought process correct, will not be going a long way to achieve these lifestyle modifications in this given clinical setting. So it is very important that we look at cognitive behavioral therapy and individualize our counseling to each person who is sitting across us with this PCOS, and where lifestyle counseling has become important. So goal setting, self-monitoring, stimulus control, problem solving, assertiveness training, slower eating, reinforcing changes, and relapse prevention to optimize weight management. And one should be very realistic in advising, because first ask yourself, will I be able to do it if I was in that position? How would I manage it on myself before advising it to the others? So this part needs to be looked at psychologically as to how the behavioral changes is important here for a person to maintain long term. Just losing it for a few months and again getting it back will be a waste of time and it will be futile. So this needs to be a constant change. So behavior is the important part, feeling is important, thoughts are important. The person needs to be convinced by us as to what is being explained regarding this particular scenario. Now, dietary intervention, an energy deficit of 30% or 500 to 750 kilocalories, that is 1200 to 1500 kilocalories, considering individual energy requirements, body weight, and physical activity levels. practice healthy eating habits. So of course, we are all convinced that this does help in PCOS. We need to manage our diet. We need to manage our exercise schedules, what to eat, how to eat, and right thinking. For prevention of weight gain, adults 18 to 64 years, again, this is from this international guideline of 2018, 150 minutes per week of moderate intensity physical activity or 75 minutes per week of vigorous intensity physical activity. Adolescent, 60 minutes moderate to vigorous physical activity. For modest weight loss, prevention of weight regain, 250 minutes per week of moderate intensity activity or 150 minutes per week of vigorous intensity activity is advised to these patients. Physical activity could be walking, cycling, games, sports, occupational work, household chores, etc. 10,000 steps is ideal. 30 minutes of structured physical activity. Now this is again SMART, which I'm repeating here. It is specific, measurable, achievable, relevant, time limited. Goals could include 10-minute bouts, progressively increasing physical activity 5% per week. So it has to be slow. It cannot start with a vigorous activity right in the first week. So one should go very steady and slow as to what. It should not be painful for the person who's doing it or sore muscles. They should enjoy and then do it. Even a 5% of body weight will reduce insulin resistance and circulating androgens, resulting in spontaneous ovulation and relief of symptoms. Writing the prescription. This was a good one I came across in some paper which says writing a prescription again is very important. As I said, individualize it. Fit, VP. Fit, very important. What is fit? F is frequency, 5 days a week for exercise. I is intensity, which should be moderate and graded slowly. Type of exercise, aerobic exercise. Time, it is 30 minutes per day. Volume is F into I into T, that is 150 minutes per week, moderate intensity. Progression, start low and go slow. Exercise should not come across as punishment. It should be long-term adherence is based on enjoyment. Patient should never be sore or in pain, but she should be challenged. A challenge is encouraging, engaging, and rewarding if it increases enjoyment. Start low and go slow. So knowing is not enough, we must apply. Willing is not enough, we must do. Should lifestyle modifications be advised before IVF or directly take up for IVF? I, being an infertility specialist, I thought I will include a few slides regarding what we face as to how we counsel our patients in settings of infertility. So obesity and reproduction, a committee opinion, difficulty in imaging due to adipose tissues, increased gonadotrophin use, increased duration of stimulation, increased follicular asynchrony, increased cycle cancellation rates, poor response to superovulation, reduced HCG concentration on the day of oocyte pickup, reduced number of COC, reduced M2 oocytes, reduced good quality blastocytes, reduced pregnancy rates and increased miscarriage rates. So effect on endometrial receptivity. So of course, it is directly related to infertility. It is important to counsel this set of patients and put them on lifestyle modifications for sure. Other than infertility, menstrual irregularities, type 2 diabetes mellitus, hypertension, liver disease, reproductive disorders, heart disease, later on in life, the cardiovascular accidents, dyslipidemia, these are all part of it. So effect of obesity treatment on female reproduction results do not match expectations. Yes, this was a paper which I came across from 2017, fertile sterility. This is an important one. It says that the adverse effects of obesity or female reproduction have been extensively documented. However, there are few prospective studies that have examined preconception weight loss interventions. There is no clear-cut definition as to what should be the weight before you can offer these treatments. There is a need to develop successful interventions with significant weight loss and compliance, and most importantly, document the effect of preconception interventions on important perinatal outcomes such as live birth and the health of the infant and the mother. The existing data from randomized trials that come closest to meeting these criteria have failed to document improved live birth rates after the intervention compared with the control groups. So there's a tendency to equate results from most successful treatments of morbid obesity, that is only bariatric surgery. So what do we do in this subset? Further research priorities for treating obesity in preconception. Primary outcomes practice changing studies should focus on perinatal health and not weight change. establish an optimal dose of weight loss by dose response studies, identify the optimal initiation of infertility therapy in relation to weight loss, expand studies to use pharmacological agents with acceptable perinatal risk, perform prospective randomized trials of bariatric surgery, explore the utility of establishing weight or BMI cutoffs for receiving infertility therapy, use personalized medicine approaches to patients for preconception therapy and specific therapies. Initiate obesity prevention therapies in overweight adolescent females. It begins right early there. So bariatric surgery, of course, is not a part of lifestyle management, but it is the last resort for morbidly obese patients. And of course, then 2 years waiting time. And again, the perinatal outcomes in this still remains a question mark. So PCOS, of course, is a multidisciplinary approach, but lifestyle plan and support and counseling is important here. So to conclude, I would say obesity and sedentary lifestyle in PCOS is associated with anovulation and failure of infertility treatment. Lifestyle modification.
Excuse me, Dr. Jyoti, there is another 1 minute. You can finish by then.
Yeah, the last slide, ma'am.
Yes.
I'm on the last slide.
Yes.
So lifestyle modification, weight loss and exercise prior to infertility treatment improves ovulation rates and are recommended as first-line treatment. The best diet and exercise regimes are unknown, but a caloric restriction and increased physical activity are recommended. The ideal amount of weight loss is unknown, but a 5% decrease in body weight might be critically meaningful in this subset of patients. Thank you very much.
Yeah, fine. It's an excellent presentation. And, very many things have to be discussed in the discussion time about the holistic lifestyle approach. And the next speaker is Dr. Rohan Palchetkar. And
can you stop your sharing, screen share?
1 minute, sir.
A young person having many positions and, Dr. Rohan. Yes. Yeah, his topic is ovulation induction. It's a very well expected topic of today. He is holding the post of head of the unit Bloom IVF, second joint secretary of AMOGS, and joint treasurer of Maharashtra chapter of IAGE, managing committee member of MSR, Maharashtra chapter of ISAR, and managing committee member of MOGS, associate professor at D.Y. Patil School of Medicine, a recipient of Foxy Korean and Foxy's Chanti Yadav Award for Infertility, recipient of FOG Young Gynecologist Award 2019, and ISAR Yuva Orator for 2019, Foxy Yuva Orator of 2020, and recipient of MOGS Best Youth Council Member of Award 2016 and 2019. Nice, doctor. You can take upon your stage.
Thank you so much, ma'am, for such a kind introduction. So today's topic is going to be on ovulation induction in PCOS. At the outset, I would firstly like to thank the program coordinators, Dr. Selvaraj ma'am, Dr. Sanjeeva Reddy sir, and Dr. Vijaya Ganesh ma'am for including me to be a part of this TAPISA webinar. So when I'm talking about ovulation induction, we need to understand that it's one of the commonest endocrinological disorders that's present in the reproductive age group. It's mainly associated with anovulatory infertility, and 70 to 80% of the women suffering have anovulatory infertility. So we have two main treatment strategies that focus on ovulation. One is ovulation induction. Basically, that's what we are going to try in patients who are not ovulating, especially in patients of PCOS. And then there's controlled ovarian stimulation for women who are already ovulating but are still experiencing infertility. So both treatments are generally including some of the same medications. So I'm going to go over through the literature and also give you the practical aspects which you can use in your everyday practice. One thing what we all do is use AMH values to test any of our patients. What we have seen, and in fact the publication which came out in March 2020 has been seen that an AMH of more than 8 nanogram per ml has been associated with low live birth rates due to hyperandrogenism. So what is our target when we're looking at ovulation induction? I'm sure all of you all have seen this flow chart plenty of times. Our main aim is to try and get the FSH value above the FSH threshold so as to ensure that a dominant follicle grows. This is what happens in your regular menstrual cycle. When we are trying for monofollicular genesis, just get one dominant follicle, so our FSH window is short. When we are attempting multifollicular genesis, we are trying to increase this FSH window. The FSH window is basically the time period where the FSH levels stay above the FSH threshold. By this, we ensure that there is multifollicular genesis, so that even the follicles where there is less FSH receptors being expressed, they still continue growing because the FSH values are higher than the threshold. So I want to go back all the way to 2001, where Mitwali and Krasper introduced letrozole as an ovulation induction. Eventually, there have been studies which have shown that letrozole is a good alternative to clomiphene citrate in the induction of ovulation. So these are the various protocols that have come over all these years. So in 2001, they said that give 2.5 mg from day 3 to day 7. Then this Al-Fadhili in 2006 said, let's increase the dose to 5 milligrams per day. Mitwali and Kasper in 2005 said you can even give a single dose of 20 mg on day 3 and that's enough for ovulation. And then Badawi et al. In 2009 said that you can give an extended letrozole program from day 1 to day 10 with just 2.5 mg of letrozole. So what did this extended letrozole program achieve? We saw that higher number of patients ovulated. There were more number of dominant follicles that were present. The pregnancy rates were significantly greater, and there was no real extra cost to the patient. So with this extended letrozole program, when you see patients that are resistant even after 5 days of letrozole, you can continue it for another 5 days and do a scan again, and you will see that there is an improvement in the ovulation. I will come to a step-up letrozole program a little later in my talk. So I wanted to start with this 2001 study. I know it's really old, but this was the study that actually gave a rise to letrozole being used in PCOS. So they included 22 patients, 12 with PCOS and 10 with ovulatory fertility. The previous treatment was CC with an inadequate outcome that was either no ovulation or endometrial thickness less than 5 mm. They gave letrozole of 2.5 mg, and what they concluded was that letrozole was effective for ovulation induction in anovulatory infertility and also increase the follicular recruitment, and it also avoided the thinning of the endometrium when used for ovulation induction. This was an Indian study published in 2012, which included 204 patients which received letrozole and CC. What they saw that in the letrozole group, the endometrial thickness was definitely better, and the pregnancy rate and the live birth rate was definitely better in letrozole as compared to CC. A Cochrane review, which was published in 2018 by Franek et al., included 42 RCTs with almost 8,000 women. They saw that there was a live birth rate which was higher with letrozole as compared to CC in PCOS women. OHSS rates were similar in both, and there was no difference in the miscarriage rates or multiple pregnancy rates. So this is just showing us that letrozole definitely has a better response in PCOS patients as compared to clomiphene citrate. Now we'll come to what else can be added to PCOS patients. So one, metformin is always something that we've been talking about. It's a biguanide. It improves the glucose insulin metabolism by decreasing the glucose absorption, the gluconeogenesis, the glycogenolysis, and the lipogenesis. It also improves the uptake of the glucose by the liver, skeletal muscles, adipose tissue, and ovaries. Your dosage is generally expected to be around 1,000 to 2,250 milligrams per day. Metformin should be added where lifestyle modifications are not sufficient for prevention of weight gain and metabolic outcomes. And this was advised by the international guidelines of PCOS, which were published by Monash back in 2018. Another study published in 2019 showed that 7 RCTs were included where metformin was superior to placebo. It improved the BMI, testosterone levels, total cholesterol, and triglycerides. So in addition to what all lifestyle modifications you're doing, metformin could be considered to be added to help these patients in weight loss as well. There was a beautiful talk given by Dr. Jyoti Bali ma'am about the smart counseling. And I think maybe an addition to that could be the medical management as well, which could possibly help these patients to improve their physical as well as hormonal profiles. In 2017, a Cochrane RCT showed that the addition of metformin also improved the menstrual pattern, the ovulation rate, and the clinical pregnancy rate. And again, the 2008 guidelines, it says that metformin should be added rather than persisting with clomiphene citrate or gonadotropins alone. Now moving to ionositols. So myoinositol and dichloroinositol support the intrasol formation of this insulin secondary messengers. Myoinositols are involved in the glucose uptake and therefore higher in the heart and brain. It also reduces the release of free fatty acids from the adipose tissues. The dichloroinositols are seen in higher concentrations in the liver, muscle, and fat. And myoinositols also mediate the follicular response to gonadotropins by promoting the meiotic progression and helping in oocyte maturation. The MCI and the DCI ratio, which we all talk about, the 40:1, or how it's being provided right now in the market, it's generally moderated by the activity of epimerase. This epimerase activity is stimulated by insulin and is reduced when there's insulin resistance. So insulin-sensitive ovaries generally have a 100:1 MI to DCI ratio. However, in PCOS, due to hyperinsulinemia and the epimerase activity is enhanced, this lowers the MI to DCI ratio and is believed to play a role in the ovulatory dysfunction. Now, the Cochrane review, as well as the 2018 guidelines which were published, as well as a study published in Feb 2020, showed that the DCI evidence that DCI may improve ovulation rates. However, it did not improve BMI and metabolic syndrome. However, the evidence was not strong enough. So it was more of poor and low quality studies. So it said that cautious recommendation is advised when giving ionositols to your patient, and it should be considered an experimental therapy. Even Deepti ji et al., who published in May 2020, she reviewed 9 articles. She said it showed an improvement in the oocyte and embryo quality. However, there is no statistical significant data, and there are more well-controlled large randomized trials which are required before we can strongly say that ionositols do have an effect in the treatment of PCOS. Now, melatonin was something which I came across this study in 2019 when I was reading a few articles, and I found this article very interesting. It's seen that in PCOS patients, the serum levels of melatonin are high, but the follicular fluid levels of melatonin are seen to be decreased. This melatonin promotes the oocyte maturation and ovulation by protecting the oocytes against oxidative stress. It's basically acting as a scavenger and reducing the oxidative stress by eating up the free radicals. It's shown also to reduce weight, improve the BMI, and reduce the intra-abdominal fat. Therefore, supplementation of melatonin in PCOS should be considered. I have just recently, after reading this article, started using melatonin in my patients. It's too early for me to say whether it's really working or no. And maybe I think in another 6 months, I should be able to give you an answer whether it has worked in my own practice or not. Now coming to gonadotropins, second line agent. So your first line agent always should be oral ovulogens when you're using for ovulation induction. The disadvantage is that USG monitoring is needed, but I think in today's day and age, we are all monitoring our patients, even if we're using oral ovulogens. There's a chance of a potential risk for multiple pregnancy. However, now low-dose gonadotropin protocols optimize monofollicular development. However, there's an increased cost. Gonadotropins plus metformin can be used in patients with CC resistance, and trigger should be given only if 2 or less follicles are present. Now, we always have this argument which is going on whether your recombinant is better, your highly purified, or your urinary. So Cochrane review, which was published in 2015, shows that 10 trials compared recombinant FSH versus urinary FSH and purified FSH versus HMG. They found no difference in any of the combination, in any of the different preparations in the live birth rate or OHSS criteria. So now I want to tell you about the different protocols which you can use for ovulation induction. So when we're using the conventional step-up protocol, start with a low dose of 75 to 150. Do your USG monitoring on your day 7, day 9, day 11 as you do it regularly, and step up the dose only if it's required. Make sure that you do not hyperstimulate the patient. Sometimes you may not even need to step up and trigger once the follicles are about 17, 18 mm, and then you can just do your either the IUI or your natural conception. Generally, for gonadotropins, I would advise going with IUI rather than timed intercourse. Now, the low dose or chronic step up is basically the same thing, but you just start with a very low dose of 37.5. However, it's been seen that you require a longer time for stimulation. So I generally don't prefer this. I just prefer the regular step up rather than the chronic low dose. Now, the step down protocol is more to mimic the menstrual cycle by giving a high dose of FSH at the start or HMG or whichever preparation you prefer, and then stepping down the dose as per the regular menstrual cycle. This is seen to have a better monofollicular development and obviously give the trigger. I've written 16 mm, but generally I prefer a 17 or 18 mm. Even though I've written serial E2 levels, I generally do serial E2 levels when I'm at crossroads, when I have follicles, 2 follicles of say 17 or 18 mm and 1 or 2 follicles of 14 and 15 mm. At that point, I do an E2 level just to see if I've hyperstimulated the patient or no. Sequential regimen, basically I've written CC, but I would advise in PCOS patients use letrozole for the first 5 days, that is from day 2 to day 6 or day 3 to day 7, and then addition of gonadotropins. Obviously do your USG as per your follicular studies, which you generally do, and then give an HCG trigger on day once the follicle is 17 to 18 mm. The conjunctional regimen is basically when you're using your letrozole day 2 to day 6, but you start the gonadotropins while the oral ovulations are going on, and you follow the same pattern of USG to see how your follicles are growing and give the trigger again when it's 17 or 18 mm. So this study was published in 2013, where they basically compared gonadotropins alone versus sequential regimen. There were 90 women which were included in the study. They gave CC of 100 mg from day 3 to day 7. Basically, what they saw that there was a higher pregnancy rate in the sequential regimen. I believe that you could use letrozole instead of CC as well. You can and lower doses of HMG were also required in the sequential regimen as well. So therefore, it's as effective as HMG in terms of ovulation induction and pregnancy rates, and it is also less costly than just using gonadotropins alone. This was another study which included the step-up letrozole protocol. So I had mentioned it earlier, where a step-up letrozole, where you can increase the dose of letrozole daily, or what I prefer to do is generally I give a dose of letrozole for up to day 5 of about 2.5 mg for 5 days. If I believe that it's not growing well, then maybe step it up to 5 or 7.5 and see that the follicles grow. So what this study did was that group A received letrozole from day 2 or day 3. The dose started from 2.5 and was increased to 5, 7.5 and 10 mg. The group B received letrozole as well as gonadotropins. So they gave letrozole for 5 days and gave gonadotropins every alternate day from day 7. Ovulation rate was seen as 90% in group A, while there was a 100% ovulation rate in group B. However, the clinical pregnancy rate in group A was 10.7, while in group B was 16.7, but it was statistically insignificant. But the main thing, if you can see, is the cost of medication was much statistically lesser in group A as compared to group B, and you still got a multifollicular growth using the step-up letrozole protocol. In a country like ours, where in India, where the cost is borne by the patients, we could really consider using the step-up letrozole program if our patients are not affording for gonadotropin stimulation as well. Now, GnRH antagonist is something that has always been questioned when using ovulation induction for either IUI cycles. So this was mentioned in 2010 and 11 in fertile sterility, that almost 20 to 26% of the patients had a premature LH surge when they're undergoing COS. It's been demonstrated that there was an elevated LH levels in the follicular phase that affect the oocyte quality by early resumption of meiosis and premature oocyte maturation and ovulation. This either caused lower implantation rates or increased the miscarriage rates. So this study published in 2019 included 175 women with PCOS undergoing IUI. So there was a control group which received purely gonadotropins, and the study group which included gonadotropins plus an antagonist, which was added on day 4 once the follicle was reached 14 mm. The control group had 17.2. That is, the group that did not receive the antagonist had a 17.2% rate of premature luteinization as compared to the study group of just 1%. The clinical pregnancy rate was also higher in the antagonist group as compared to the control group, that is 25% to 14.9%. However, this was not statistically significant. So the question arises whether we are getting a success rate to the cost effectivity, because by adding the antagonist, you're increasing the cost of the patient. So even if you're giving the antagonist, say for 2 or 3 days, you're increasing the cost of the patient to close to almost 4,000 to 5,000 rupees for that cycle, besides the IUI charges which you're going to be giving. So you really have to wait out, even though the studies are showing that there's a lesser rate of premature luteinization. Of course, yes, the numbers show that you have better pregnancy rates in the drugs, but statistically, if it's not significant, we have to look at larger numbers to really get a actual result to see if...
Excuse me, Dr. Rohan, you have another 2 minutes, okay?
Yeah, ma'am, this is my last slide.
Yes.
I'm done. Okay. So in conclusion, if you go to see this slide, which was beautifully given in fertility sterility, which I had seen, when we're looking at PCOS, the first line of management for PCOS patients for infertility should be lifestyle interventions. And what Dr. Jyoti Bali has said should be followed beautifully. The first line of pharmacological management should be letrozole, then maybe clomiphene citrate if with metformin. I don't believe in using clomiphene citrate at all. And the last one should be gonadotropins. The second line of management should be gonadotropins or laparoscopic ovarian drilling. I do not believe too much in laparoscopic ovarian drilling. I believe it should be reserved for highly clomiphene resistant, where the AMH would probably be extremely high. And then the third line of management should be considered, such as IVF, when the patients are probably not responding to the first and second line of management. Thank you so much for giving me this time to talk at TAPISAR. And I once again thank the conveners for giving me this opportunity to speak.
Still, you have 45 seconds, doctor.
Ma'am, I think...
okay, nice presentation. And I think at the end, you will be the one who's going to get many questions. We'll discuss in the discussion. Okay?
Yes, ma'am. Thank you so much.
Yes, good. Thank you. So the next speaker, Dr. Chaitanya B. Nagori. Maybe most of us know who he is because he has contributed many books and topics on ultrasound in gynecology. So he's the director of Dr. Nagori's Institute of Infertility and IVF. Best paper of World Congress ISUOG 2008 in Chicago. The first stem cell pregnancy of India was done by him. Published several papers in index journals. First ever Center of Excellence for Ian Donald School of Ultrasound. And contributed in several books and authored a very popular book, Handbook of Infertility and Ultrasound for Practicing Gynecologists. Doctor, so you are invited for the topic.
Thank you very much.
Yeah. It is ART and PCOS. Very interesting topic. We expect a lot from you, sir. And people are waiting for your talk.
Thank you very much, madam, for the kind introduction. At the outset, I am thankful to Professor Reddy as well as Dr. Kamla Selvaraj for inviting me on this TAPISAR webinar. Now, all of you know that Rotterdam criteria, the two things should be present, and out of all this, we concentrate more on an ultrasound that according to Rotterdam criteria, there should be 12 antral follicles. But now you realize that the 12 has been changed to 20 antral follicles. So there are some studies that follicle number per ovary should be more than 19, and that gives a good specificity as well as the sensitivity. But on an average value of 26 or more follicles per ovary is a reliable threshold for detecting the polycystic ovaries in the woman with the frank manifestation of the PCOS. That's why your antral follicle count should be at least about 26. Lower threshold should be defined for the diagnosis of PCO as the age advances. I think my previous speaker said that once the PCO occurs, it is for the lifetime. So the same number of follicles cannot be at the age of 25 years and at the age of 35 years or 40 years. And that is why the different threshold should be there. The threshold for PCOM should be revised regularly with advancing ultrasound technology, and the age-specific cutoff values for PCOM that should be defined. And then thinking about the original description of PCOS, even still Leventhal said that there should be the sclerosistic ovaries, and stromal excess was given very much importance for the diagnosis of PCO. So the patients having long-standing PCOS, having long-standing anovulation may have more dense stroma, and this is a cardinal feature that has been shown by the presence of a bright, highly echogenic stroma on the vaginal ultrasound. So PCOM, stromal echogenicity in a normal woman, are not a morphological variant, normal ovaries, but rather represented a functional entity, a silent form of PCOS, which serum AMH could be the best marker. Now, the measurement of an ovarial stromal flow in the early follicular phase is related to subsequent ovarian response in an IVF treatment. So, to identify the woman with a milder form of PCOS, further information, particularly about the ovarian stroma and the degree of vascularization, is recognized. So, if you do a 3D ultrasound, that clearly showed higher AFC, higher ovarian volume, and higher stromal volume, and higher stromal vascularity has been found in the study. So, in vitro fertilization, IVF is offered as the third line of treatment. First is letrozole, second is gonadotropin / ovarian drilling, and third is an IVF. It is useful in single embryo transfer to avoid the multiple pregnancy. OHSS and multiple pregnancy is the hazard apart from the cost of the IVF. Now, parameters that should be included for the dose calculation, because the stimulation protocol is very important as far as the ART is concerned. And this was one of our pilot studies where from AFC, ovarian volume, stromal RI, stromal PSV, stromal FI, age and BMI, we found out that which are the cases which require a lower dose. And from this pilot study, we published a paper on ultrasound-based decision making on stimulation protocol on an IVF, and we devised a scoring system. And on this scoring system, then you decide what should be the stimulation to the patient. Now, age, BMI, AFC, ovarian volume, stromal RI, and stromal PSV. Here in a red color, you can see that 4 and 5, where these are the patients of PCO, young patients, where the value will be much more. And so from the starting dose, whenever you see the score more than 25, then in an IVF, you start with the 75 units. And if you are going to freeze all the embryos, then you can add 75 units more. So these are the cases where you start with the lower dosage. And if you want to do the freeze, then you can do a further, you can add a 75 units to these patients. Now, which gonadotropin is to be used? I think Rohan already said that the Cochrane review says that whichever gonadotropin you use, they are the same. I don't agree to this because it is only for a general, all the patients. But if you see the specific bioactivity, HMG has bioactivity of 8 international unit, urinary FSH 100 to 150, urinary HMG has 2000 units, while recombinant FSH has 10,000 units. So particularly in a PCO patients where the LH level is likely to be high, you should always use either the urinary FSH, which is highly purified, or the recombinant FSH, which is having the highest bioactivity, and that requires a lower dose of the drug. Now, the reason is that the bioactivity and immunoactivity are different at different times. If you see after the menstruation, the bioactivity is very poor. And during the peri-ovulatory period, the FSH is having the highest bioactivity. Now, the recombinant FSH, which is prepared from a Chinese larva, which is cloned in such a way that it mimics the peri-ovulatory period. And that is why the dose which is required of a recombinant FSH is always less as compared to the urinary FSH, which is prepared from the menopausal urine, which is having the least bioactivity. And that is why the recombinant preparations or the highly purified preparations are much, much better than the other urinary products. If you see the reports that recombinant FSH has got the higher pregnancy rate, and if you see the prospective analysis of 24,000 ART cycles in the German registry, they have found out the lower dosage with recombinant FSH than the HMG. Second thing is in PCO patients, the LH level is always high. And if you use HMG to these patients, you are adding more LH to the patient. And by adding more LH, you never know how many ampoules the patient is going to consume. And that LH level may cross the ceiling level. And if it crosses the ceiling level, it spoils the quality of an ova. A classical example is clomiphene citrate, which secretes the FSH and LH. And a higher LH level spoils the quality of an ova. And that is why the ovulation rate is very high, while the pregnancy rate is very low. So if you add HMG to all the patients of PCO, then you are adding more LH to the patient, which may be detrimental as far as the quality of an egg is concerned. And that's why in a PCO patients, for the stimulation protocol, either rely on the FSH only, but never combine FSH plus LH. I have seen there are only few patients where the LH is to be supplemented, and that is not the subject here to be discussed. But otherwise, routinely, you should always give the FSH to all these patients. Now, the antagonist protocol. Recent meta-analysis comparing the antagonist and agonist protocol showed significantly reduced rate of OHSS and less severe disease. In a patient of PCO, as far as the ART is concerned, we are afraid of only two things. One is a multiple pregnancy, and second is an OHSS. And for that, the antagonist protocol has been found to be very good. Now, when you are using an antagonist protocol to this patient, there are two things. Either you can start from day 5, or even if the LH level is high, you can start from day 2. But do not start when the size of the follicle is 14 millimeter. That is a flexible protocol. Flexible protocol is possible in a normal responding ovaries, but not in a PCO patient. In a PCO patient, there are multiple follicles, and the amount of estrogen on day 5 or 6 is much, much higher. And the estrogen that causes an LH surge rather than the size of the follicle. And that's why here the antagonists are always started, even if the size of the follicle is lower, you should start antagonist to this patient. Now, these are the patients in a PCO patient, you give an antagonist to the patient, and then you give the agonist as the final maturation. Here you are giving GnRH agonist as the final maturation. The only thing is that GnRH agonist has 24 to 36 hours duration. It leads to lower LH and FSH, resulting in a corpus luteal deficiency. So whenever you use GnRH agonist, there is always a luteal phase deficiency. But GnRH antagonist protocol is recommended for PCOS women and is predicted with the high responder women with regards to improved safety and equal efficacy. GnRH agonist will not cause the OHSS. We are coming to that point afterwards. But when you give agonist, this causes an LH surge as efficiently as HCG. And second thing, there is no differentiation between the oocyte maturation, whether you give HCG or whether you give GnRH trigger. But additionally, it always gives an FSH surge also. In the human being, perhaps the value of FSH surge is not known, but in animals, FSH surge is always required. And there are a lot of papers which are available that if the FSH surge is simultaneously given along with the HCG surge, then the pregnancy rates are higher. Second thing, in an endometriosis also, instead of giving only HCG, if you give the GnRH agonist trigger, which gives an FSH surge, then luteinized unruptured follicle does not occur. So this is also one of the treatment for luteinized unruptured follicle. Now here the lower doses of E2 and progesterone, and therefore it is very good for implantation. Short duration causes less corporal lutea, reduces the risk of OHSS, and choice is for OHSS free clinic. We are discussing this afterwards that nowadays younger generation, younger population, you are not well versed with the patients of OHSS because we have practiced in an era when the antagonists were not available. And with the agonist also, we have faced a lot of problems of OHSS in some of the patients. So now, at least for an OHSS free clinic, because OHSS is simply a nightmare for the practitioner. And that is why you should go always for OHSS free clinics. That's why antagonist protocol with an agonist trigger is always the choice. Second thing, it is always for donors. It is the treatment of choice. Antagonist plus agonist trigger. It is useful in LUF, and more M2 oocytes are always gained. Now, whenever you get a GnRH agonist trigger, then The question about you, whether you would like to transfer in the same cycle or whether you would like to freeze the cycle and then you have to transfer in the next cycle. If you are going to transfer in the same cycle, then intensive exogenous E2 and progesterone are to be given. And here you can give progesterone as well as the estrogen to this patient, and vaginal progesterone or the intramuscular progesterone can be added. Here the pregnancy rates are very good, particularly, but there is always a risk of OHSS, and if the pregnancy occurs, the incidence of OHSS is very high in these patients. Second is a dual trigger. Whenever you give an agonist trigger, there is always a chance that the LH surge may not occur. And LH surge minimum requirement is about 15 international unit. And if you don't get a 15, then perhaps you will get an empty follicle syndrome from one ovary. You have to give HCG and then you have to once again do the pickup after 36 hours. Instead of coming across this situation, always give 1000 units to 2500 units at the time of a trigger. That will take care of the meiosis, and that's why you can do a fresh transfer. There are 53% pregnancy rate has been recorded with this dual transfer. So dual transfer is particularly for two types of patients. One is for the fresh transfer, and second thing is if you want to avoid whether the LH surge occurs or not, because long-standing OC pills the patient has taken or the initial LH level is very low, then these are the cases where the LH surge may not occur along with the antagonist, along with the agonist trigger. And at that time, you must give a dual trigger. And third is HCG. Whenever the E2 level is more than 4000, you always freeze all the embryos. But V2 is less than 4000, or you get 25 embryos of less than 11 millimeter, less than 25 embryos of 11 millimeter size. Then you give 1500 units of HCG at the time of ovum pickup. If you give at the time of an ovum pickup, it rescues the corpus luteum and takes care of the luteal phase. That is why this is Professor Humidian regime, that whenever you get less than 25 number of eggs, always give 1500 units of HCG. But occasional cases are always reported in the literature that it can cause occasional cases of an OHSS. Recombinant LH, very expensive and it is not used. But the imminent risk of OHSS, the best thing is to all embryos should be frozen and transferred in the subsequent cycle, and that results in an excellent pregnancy rate. So in majority of the patients, for the prevention of an OHSS, and particularly in PCO, you have stimulated the patient, the more FSH is given to the patient, and that can give a progesterone rise of more than 1.5 nanogram per ml. That is not favorable as far as the implantation is concerned. So in both this situation, you have to freeze the embryo and you have to transfer it in the next cycle. And in freezing the embryo, the artificial cycle, modified natural cycle, the results are the same. But in an artificial cycle, you can give progesterone and you can give the injectable aqueous solutions. Then also the pregnancy rates are very good. At present, the best method as far as the treatment of PCO is concerned is a segmentation of ART. Segment A is optimizing an ovarian stimulation with an antagonist cycle and give an agonist trigger. Segment B is vitrification or optimum cryopreservation of all the embryos, and segment C is embryo replacement in the non-stimulated period. Now, freeze all, late OHSS is prevented. It does not affect the results, but there are still the controversial data available to us. Now, the only question is OHSS. If you have a segmentation, then you will not come across the OHSS in your practice. But those who are doing a transfer in the same cycle, perhaps they may use a metformin, or these are options available for avoiding an OHSS. Metformin, of course, this now does not happen if you are going to use an antagonist cycle with an agonist trigger, and if you are going to freeze the embryos, then there is no role of metformin as far as the prevention of an ovarian hyperstimulation. But if you are doing a fresh cycle, then this only slide will be enough, that by just even not the estradiol is required, you do an ultrasound and find out the volume of the ovary, and this volume can tell you whether the patient will end into an OHSS or not. So use GnRH agonist trigger, freeze all embryos, segmentation of the ART. This will be the best as far as the prevention of an OHSS is concerned. Nowadays, there is no role. I think majority of the clinics are using an antagonist cycle. There is no agonist down regulation and then HCG trigger and then to have coasting or low dose of HCG or HES or glucocorticoids or albumin. These days are gone. This is we have practiced when antagonists were not available. But now as the antagonists are available, we always go for freezing. I've already discussed agonists, and that's why only even the dopamine, that is an cabergoline, is not, even that is also not required if you are using an antagonist cycle and giving an agonist trigger. The OHSS does not occur to the patient. So once again, I repeat that the segmentation is an excellent. Those who are the beginner practitioners, please use antagonists and give an agonist trigger, and you should have a freezing facility. Then you can avoid OHSS, because in ART, this is the only complication which is not digested by the patient. That's why try to avoid OHSS simply by segmentation of an ART. Thank you very much.
Thank you, sir. You are in time, and I think people are going to discuss with the type of gonadotropins to be used for ART. We're expecting questions from the participants. Now, so out of the explosive response to the follicular growth for the gonadotropins, do you like to have some pre-treatment for PCOS patients, preparing them for ART before you give gonadotropins and downregulate them or give stimulation?
Those patients, in some of the patients, the LH level may be high. Then we start the antagonist from the first day, or rather the second day, that is from the day of stimulation. But otherwise, whenever the patient comes to you for infertility, I think our setup is different. We are all private practitioners. And if you ask the patient that you reduce the weight and come to me, I think your neighbors will be much more happy than you and your neighbors. So there is no question of telling the patient that now this. Only thing what you have to observe is that the patient should not end into any complication, and what your expectation. So I will see an AFC, and according to the AFC, I will stimulate the patient and I will freeze the embryos.
Do you give any pre-treatment to them, like metformin, or advise them to go for drilling?
There is one disadvantage of metformin, because you will get less number of eggs if the metformin is given. Metformin came into existence only for the prevention of an OHSS. But I am already giving antagonist, agonist trigger, and I am going to freeze the embryos. There is no question of OHSS. And that is why I will not give metformin, because I will get less number of eggs.
How do you expect the OHS? You anticipate OHS by the number of follicles or by going behind E2 evaluation?
We always go by first is you stem the diagnosis of OHSS, and once we stem the diagnosis of OHSS, then we always give antagonist, agonist trigger and freeze the cycle.
Okay.
Because you never know which patient is going to develop an OHSS. So even your E2 value may be wrong. By the laboratory may have given you 3500, and exactly at that time when you are going to do a pickup, it is already the evening. And at that time, perhaps the estradiol has gone to 4500 and you are likely to end up in an OHSS. So that is why all PCO patients, that should be a dictum nowadays to avoid OHSS, that you give antagonist, give agonist trigger and freeze the embryo and transfer in the next cycle. Excellent results.
Yeah. In your experience, which gonadotropin, like recombinant FSH or urinary FSH, give better results?
I too, there are a lot of papers, and I can talk for 1 hour on this subject, because I know from the beginning of a Pargonal we have used FSH and LH combination, then came Matrodin, then came Matrodin HP, then came Gonalab, then all these preparations which have come. And there are a lot of papers available in the literature, but still I believe in physiology. You try to understand what the physiology says. If you see the FSH which is secreted after the menstruation, the same FSH is having the lower bioactivity and the amount is small. But in a physiological cycle, in a natural cycle, if you see the FSH which is secreted, so at the time of an ovulation, the bioactivity is very high, but the amount secreted is very low. So that is why you should have a good bioactive drug that helps you a lot. And recombinant FSH is prepared from a Chinese larva which is cloned in such a way that it mimics the bioactivity of a periovulatory period. And that is why the dose which is required of a capacity is always less. And second, I tell you that whenever the research comes and when that research lasts for a longer time, only those companies who are not having those products will argue about those products. Otherwise, majority will accept it. And in a medicine also, whenever the newer research come, the newer drugs come, people always accept it and then they proceed further.
Yeah, and your experience with the recombinant LH, if any?
Recombinant LH, I will tell you two things. All the patients, they don't require a recombinant LH. There are only two groups of the patients, Poseidon group 1 and group 2, if you see, that where you expect that the result should be very good. But in spite of that, you have not received an OVA. And this is the stage where the LH level. If I tell you the Doppler finding, the vascularity will decide that how many gonadotropins will be delivered to the ovary. And whenever the vascularity is less, at that time less gonadotropins are delivered. And these are the cases which are poor responders. These are the cases where the LH is to be supplemented. Second is bioactivity after the age of 35 years is definitely less as compared to the bioactivity of LH which is present before 35 years. And that is why after the age of 35 years, the LH is required to this. And third is LH polymorphism, where you would require the recombinant LH to be given to the patient.
Thank you. Thank you so much for your elaborate talk on gonadotropin, sir. Thank you. Thank you so much. So the next question goes to Jyoti Bali on lifestyle management, the holistic approach. Could you able to tell us the real, the diet schedule? Instead of telling low calorie, low carbohydrate like that, how do you counsel your patient practically? When the patient is sitting in front of you, in your language, colloquial language, you have to imbibe some idea about the carbohydrate, protein and fat content of foods first of all. And
yes.
How do you define?
Yes, first of all, it has to be a very gentle counseling. The patient shouldn't get offended that, you're pointing out at her weight. The art of counseling is very important here because as Dr. Nagori said, otherwise in my infertility practice, the patient will definitely go to the next door clinic and not be with us. So the counseling has to be that, look, today it is your weight is 90 or whatever, 80. It is only I'm expecting for this treatment to resume 5% of body weight loss. So calculate the exact amount and tell her in kgs as to what is 5% of her today's weight. So it will be 4 kgs or 5 kgs. And then you say, I'm not expecting it overnight. I advise you to go over a period of 1 month, 2 kgs. Second month, another 2 kgs. If I'm giving 2 kgs and if you lose 1.5, I am fine with it. And yet if your efforts, consistent efforts of 2 months or 3 months doesn't fetch you this result, don't panic. It's only maybe sometimes the weight loss takes a longer time. It may be inch loss around your abdomen area where the fat deposition is the maximum for women. And infertility, even if that fat loss near the abdomen area is lost, well, I may get my desired results. It may be helpful for us to begin your infertility treatment. So there is no need to panic. So the counseling needs to be very gentle about it, realistic about it. And in terms of diet, what do you eat for your breakfast, lunch and dinner? Take a schedule. Then be very practical that instead of having dinner at 9, try having it before 7. Then morning breakfast, these are the items that you can take which are low in carbohydrates, rich in protein. If she's eating eggs, well, advise her boiled eggs. But every day she won't have the same breakfast. So give her varied options as to what protein containing breakfast could be. Then let her not eat the entire breakfast at 8 o'clock or 9 o'clock. She can divide it into 2 meals. If she's had half the portion at 8 o'clock or 9 o'clock, after 2 or 3 hours, she can have an apple, maybe include a fruit in the diet. So that will keep her stomach full. There is no dieting, but there is at the same time, the diet is appropriate and the right kind of diet. If she has a lunch at 1, divide it into 2 meals. Have it at 1:30, 1 o'clock. Then again, 3 o'clock, she can have some biscuits with tea. Which biscuits? High fiber diet containing biscuits. Give her 1 or 2. Then by 5:36, when she's reaching home, she can have an early dinner by 7. She'll say, but I'm awake till 11 in the night and I'm hungry all of a sudden. Then what are the things that she can include? Peanuts, almonds, or some fruit at that point of time, but not sweet fruits. But then once in a while, cheating day. You can give her a cheating day once in a week or 10 days. Because she has a family, she would be wanting to eat, craving would be there because she's cooking for everybody, or maybe she sees the food in the kitchen. And then cheating is allowed. So once you give her this flexible protocol, the motivation is it's for a longer time. The results desired in the clinic are going to be much better. It is a smart prescription, smart counseling. And if you feel that some nutritionist is needed or a gym is needed, then give her, it is not necessarily she would like gymming. Give her some dancing, maybe some dance form which has cardiovascular activity, pilates, or any other Pilates.
Zumba dancing.
Pardon?
Zumba dance.
Yeah, Zumba dance. Whatever Rohan would mention.
Okay.
Dancer, I'm sure about it. He'll tell us.
Okay.
So,
Yeah,
I mean,
it's nice.
Any activity. It could be cycling, maybe a stationary cycle at home, or maybe a cycle where near a house where the facility exists. So it depends upon a person's surroundings that one needs to know about her personal self before you dictate terms and conditions to her. Okay. So personalize the protocol and your advice to her. It will.
Yeah, you mean to say in a nutshell, the diet, I mean the timing of diet, instead of 3 times per day, she may take even 5 to 6 times a day, and most of the high calorie food should be in the daytime rather than the night time. This is the point you mean.
Yes.
Okay. So how do you feel in your practice? Like, are you approaching in a holistic way, adding yoga?
I believe in mind, body and soul.
Yes.
Mind, body and soul.
Good.
Ma'am,
nice. Thank you, doctor.
Add a little bit of this things to it. Generally, when they're talking about especially obese patients, they find it a little difficult to think of losing only 2 kgs in a month or even 2.5. Yes. They want quick results because for them it's always the biggest difficulty is maintenance. Okay. So they are looking at quick results. So sometimes in those situations, it's important that, as Jyoti Bali ma'am said, that it's important to include a nutritionist at the start itself. Yes, we are giving the advice, but I think it's important to get a nutritionist at the beginning itself so that we do have a multidisciplinary approach, a holistic approach. I completely agree with ma'am saying that gym may not be the preference of choice of exercise for a lot of people. Especially now, even if you look at this COVID era, I don't think everyone's has the access to the gym. You could just tell them something as simple as, if you're watching TV, rather than sitting and watching TV, just walk in front of the TV for half an hour, 45 minutes, because that's as long as your programs are going on. So that could just be a simple practical aspect which could improve.
Even the mobiles have got the app for counting the steps nowadays. Exactly. It has been documented as an activity which can just keep you, don't sit. It is just keep, walking up and down in a small area itself. That goes a long way because the entire day you would have finished your steps by then.
Yeah, as you rightly said, the freak days or the cheat days should be there in between for dieting, and they call it as 80-20 ratio. 80% of the time they can take the prescribed low carb and high protein diet with a moderate fat, and 20% of the time they can have their own diet being loved by the family members or along with the family members. So that's how dieting can be. Maybe it could be done in a better way with a dietitian or nutritionist. Anyway, we should also be in a position to counsel the patients in our clinic. And next to it, some papers on naturotherapy and yoga also says the reduction in free testosterone, androgen levels, and your FSH, LH, everything had been counted in certain studies, and they had come out with a good result, like hydrotherapy, mud therapy, and many things talks about PCOS widely in all medias. And I feel this is a nice discussion we had on PCOD lifestyle management and dietary aspects. And of course, Dr. Rohan, anything else to be highlighted from your talk, like ovulation, induction in IUI and natural cycle?
If you're trying for natural cycle, I generally don't prefer to add gonadotropins to the cycle. I think a letrozole protocol with a slightly high dose with a 7.5 mg dose can give good results. Sometimes it could be seen that even with patients with a slightly higher AMH of say 7.5 or 8 and above, you may require extended letrozole program of even 7.5 mg of 10 days of stimulation with a slightly higher dose could be required. And also this new step-up letrozole program which has come up is something which I'm looking into myself, and I've been seeing that the patients are ovulating for natural.
Sir, we can finish. Yeah.
There are only 2 papers, one for and one for. There are only 2 papers available in the literature on which we cannot rely. Second, very important thing I would like to tell you, that the whole idea of monofollicular development is lost when
Sir,
you
I absolutely agree with you, but I think
then why not to give clomiphene?
I think
we are not giving clomiphene because we want a single follicle, and if you want the multiple follicle, then clomiphene will be much more cheaper than letrozole.
Definitely, I completely agree with you, sir. But in the current Indian scenario, if we go to look at it, the time to pregnancy has to be reduced. In addition to that, all the papers which talk about monofollicular studies are coming from international papers, where generally they do see the expense of this. I completely agree with you that you're looking at monofollicular growth, but in India, somehow the acceptance of twin gestation is a little more, if you go to look at it, and I think the time to pregnancy needs to be reduced as well. So maybe
Doctor, sorry to interrupt. There are a few questions to be finished within a few minutes. Let me go to the next question. You don't mind?
Yeah, I'm sure.
Yeah, the best antagonist and agonist which you use in your practice, sir, and their dosages. Dr. Eka P to Dr. Nagori.
Antagonist I use, one is of Citrolix, that is from Intas, second from Ovirelix, that is very good from Sun Pharma also. And for agonist trigger, we use mostly the decapeptyl, that is from Ferring, and many a times we use the leupride acetate 2cc that can be given.
Another question for you, sir. What is your advice for obese PCOS not responding to normal stimulation protocol? By Dr. Sudha.
I'll tell you that whether it is obese or non-obese, we always rely on our calculations. That is an ultrasound calculation, and then we decide the dose. Then that obese patient will be responsive. So mostly they are not responsive because your dose calculation is wrong. If you calculate your dose according to an ultrasound, then that patient will be much more responsive, and you will definitely TOVA. And antral follicle count is very important, because in an obese PCO, it's not necessary that the antral follicle count is very good. Many times it is less, and you get only 60% of an antral follicle count as an OVA what you collect.
Yeah. Another question is, which agonist trigger and the dosage, sir? Dr. T.P. Kanaka.
That decapeptyl we use as an agonist trigger, 2 ampoules together at a time.
0.2 milligram, you mean to say, sir?
Yes, 0.2. Yes.
Another question is, if serum E2 is more than 4,000, can we still give dual trigger if LH is less? When we plan to freeze all, and in that case, how much HCG? Dr. Mohana Pramila.
See, whenever the E2 level is 4,000 units, particularly when you give an agonist trigger, and by giving 500 to 1,000 unit of HCG, you are not going to get an OHSS. I always prefer a dual trigger. Whenever I give an agonist trigger simultaneously, I always give 500 units to 1,000 units of HCG. See, if you see the physiology, then what give 10,000 units we are giving for the rupture of the follicle in an IUI cycle, only 500 units are required for the completion of meiosis. 9,500 are required for the rupture of the follicle. And here we are doing a pickup, so there is no need of rupture of the follicle. Okay. And then 500 to 1,000 units will complete the meiosis.
Maturation, yes.
Then you will pick up. So we always prefer a dual trigger, and then to freeze the embryos.
Okay. Okay, sir. Nice. Thank you, sir. Another question for Rohan. Yes. Would you like to go, in which occasion you want to do lap drilling?
I'm generally not a big fan of laparoscopic ovarian drilling. I think
there are few occasions in which you need to do.
I think maybe in patients where I see an AMH of very high, like above 18, 19.
AMH or LH?
AMH when I'm looking at, ma'am. Yes. Specifically AMH, when I look at a very high AMH and maybe they haven't responded, that's when I generally usually consider this. I don't have too much experience with the drilling aspect of it. So if Jyoti ma'am or Nagori sir would like to
Can I add something here? Yes. Can I add something here to Rohan?
Yeah.
Even I am not a proponent of laparoscopic ovarian drilling, but in a case where laparoscopy is being done for, let's say, some other indication, and a young patient where IVF may not be the cause, just 4 punctures in the ovary and current rule of applied, current of 40 volts, 4 punctures only, not that you puncture entire ovary. So if that much can be done, well, this patient may benefit conceiving without IVF.
And so when you want to, when you want to avoid
special
IVF,
settings.
Yes, when you want to avoid
special
IVF,
settings.
Yes.
Special settings.
Okay. When you want to avoid IVF, either by for economical reasons, or for the age of the patient, or when you want to avoid IVF for religious purpose.
And that was being done for some other reason, maybe endometriosis or any other reason. We've done in sperm count, normal tubes, patent. Yes, young patient, I might give her 4 punctures each ovary, and it's a huge PCO, as AMH Rohan mentioned, would be one.
So those days,
we'll be talking about it.
Those days, veg resections were done.
Madam,
instead, yes.
Madam, can I tell?
Yes.
2 things I would like to tell. One thing is those patients who cannot come for a follow-up. You do an ovarian test, let them go, and after 1 year they will come with a child. If you see, there are a lot of patients who cannot afford gonadotropins, who cannot afford the treatment, and they are coming from a distant villages. It is better to drill and let them go. They will come with the pregnancy. I don't agree with Jyoti as far as the number of punctures are concerned. I have written in my book, I have given the full explanation to it. And there are a lot of papers that the number of punctures should be done according to the stromal
volume of the ovary.
Yes, and that could be one, but it can't be multiple punctures and leaving.
Yes,
there are a lot of patients who have not improved at all by 4 punctures. So your number of punctures should be according to the stromal volume. And if you do it, then and then your AMH will decrease, and then there will be spontaneous ovulation.
And it is essentially for resistant ovaries, I suppose.
Yes. CC failures.
Yes.
May I ask a question to Dr. Naduri? Your extensive, experience with the ultrasound of the ovaries. We label everything as polycystic ovaries, but in reality, we see different patterns. Some with more stroma, some with a necklace pattern, some with a honeycomb appearance, and some with a small volume but multiple follicles, large volume, very few follicles. So, what is your interpretation? Who has got which ovary has the best prognosis, or which ovary you would say worst prognosis? Different subsets in your ovarian picture.
That's why I told you that the vascularity is very important. How much vascularity is present in the stromal structure? If there is more vascularity, then this ovary will respond very well. And if there is no vascularity, or the vascularity is very less, then that ovary is not going to respond to you, because the drug that will be delivered to the ovary will be quite less, and that is why you still require the higher doses to get a follicle. So the vascularity will tell you what stromal flow.
Stromal volume. I'm asking, what is the importance of stromal? Some people you see dense stroma. And do you have any interpretation for that?
Even if the stroma is dense, that is because of the chronic anovulation that has occurred in that ovary since long. But if there is a vascularity, stromal vascularity is very good, then the response is very good. If the stromal vascularity is less, then the response will not be very good. So that's why I always concentrate on vascularity. I just give you a simple example. A PCO of a thin, lean PCO patient, if you see, vascularity will be excellent, and they are always prone for OHSS. While obese patient, if you see, even if they are PCO, the vascularity will be very less, and they are less prone for OHSS rather than the thin, lean PCO.
They might produce very few.
Thank you.
Yeah, thank you.
On behalf of TAPISR, I thank Dr. Jyoti, Dr. Rohan, Dr. Nagori for excellent talks, and Dr. Nirmala for moderating it very nicely. At shortage of time, we have to cut short the thing. Sorry.
Thank you, sir. Thank you for the opportunity
given by the
organizers.
Whoever logged in as participants and faculty also, they can download their certificate. Just on the same registration link, if you click, it will come their download certificate. You can click on that, you will get the certificate. Thank you.
Thank you, sir.
Thank you, sir. Thank you so much.
Thank you.
See here, you can see there is a download like that link will come.
Okay.
Station, you can project once more. Okay. Just see here, if you click on the download link, certificate, it will come. You can download. Thank you. Okay. Stop sharing. We'll go to the next session. Dr. Vijay, sorry, I couldn't. This is the active executive member of TAPISR. She is consultant at New Life Wellness Center, Alwarpet, Chennai. She did her MBBS in Madras Medical College, MSc Genetics in Ramchandra Medical College. She is doing her PhD. She is almost over submitted. She will be getting any time. Her achievement felicitated on Doctor's Day at Madras Medical College by TEMA. Committee member, TAP sir, I told you. Best Doctor Award bestowed by Dr. MGR Medical University, presented by the government of Tamil Nadu by the governor. And also she got Lifetime Achievement Award given by CMJF Lion S. Kalamati Region 6 District. So much. I request Vijaya to introduce the next moderator for the session. Vijaya?
Can you hear me, sir?
Dr. Vijaya?
Can you hear me?
No, volume is low. Slightly more. Increase.
Oh, can you hear me, sir, now?
Yes.
Hi. Here I would like to invite Dr. Kanaki Uttaraj, Director of Tamari Fertility Services, Coimbatore, and so many branches: Coimbatore, Salem, Chennai, Tirupur, Pollachi, Ooty. Sir, I'm not able to see her other achievements. And Dr. Kanaki, she's a very famous infertility specialist, and she's very active in all of her.
She's very famous. That's why she's not giving any other things. Everybody should know like that.
And she's very good. My senior.
Okay. Kanavi, you can introduce the first speaker.
Okay, thank you, Drs. Vidya Ganesh and Dr. Reddy, for this opportunity. It's a nice monsoon evening here in Pollachi, and I'm thankful for the IT technology for us to communicate in this COVID scenario. And of course, I congratulate Dr. Reddy for his wonderful, keeping the chain of webinars going without a sag. Congratulations there. And the next speaker for the session is Dr. Priya Bhavichitawar, President of she's got obviously a lot on her CV. She's received the best, starting from the best outgoing student president of India award. She's obtained a fellowship in reproductive medicine from CMC Vellore, Foxy, and she of course passed with distinction. Foxy recognized trainer in basic and advanced fertility and infertility management. First doctor in MP to hold a subspecialty qualification in reproductive medicine. First professor of reproductive medicine in the whole of North India. Started the first DM course of reproductive medicine in India. Best paper award for the thesis on the role of GnRH antagonists in the ISAR 2010. The best paper award in ISAR 2012 for the hysteroscopic management of adenomyotic and myometrial cysts. And the author of Cochrane Review, a menstrual disorder and subfertility group. And the first very prestigious thing, the first Indian peer reviewer of the Cochrane Infertility Group and author of the Cochrane Sexually Transmitted Infections Group. Over to you, Dr. Priya Bhavichitawar, and she will be discussing on laparoscopic, a very controversial topic here, laparoscopic ovarian drilling in PCOS. Dr. Chitawar.
We are not able to hear.
Yeah.
Just check your.
Madam, request you to kindly accept the unmute request.
Yeah, is it okay now?
Yes.
Yeah. So thanks a lot, Dr. Reddy, for inviting me for this wonderful webinar. This is a topic which is really very important to be taken, because just as we were listening to the discussion in the previous session, things regarding drilling are not really, we don't still have that kind of consensus among all of us. And at least in the part where I practice, drilling is really misused and done for patients where it is absolutely not indicated, and we have to then look after as ART specialist women with reduced ovarian reserve who come because unindicated drilling has been done for them. Now drilling is something which I personally feel, in my opinion, is a procedure which is kind of going, it is on its way out. The recent Cochrane review also corroborates that. We will come to it eventually. But for the sake of the juniors who are here listening to this webinar, the way the drilling is supposed to act is that it destroys the ovarian stroma. And I think everything that has to be taught about ovarian drilling depends upon this one fact, that it is actually the ovarian stroma that we are after. Most of the misconceptions, most of the side effects, most of the problems that we face with drilling, they arise because we forget that we are after the stroma, we are not after the ovarian surface. Now, they do also say that it increases the blood flow and it kind of restores the synchrony. But the basic mechanism, now there is a consensus that basically it is the reduction in the androgens, which is done by destroying the stroma. Stroma is the one which is producing the androgens. And this kind of restores the LH-FSH balance and brings about the ovulation. Now, if we just go back to our MBBS days and look at the ovary, the ovarian follicles, they are on the surface of the ovary. Deeper than the surface, that is, if you go deeper from the ovarian cortex, you find the stroma. Stroma is the part which is secreting the androgens. And finally, the deepest part of the ovary is the medulla. Now, all of us have seen really horrific pictures of the ovary, where the ovary is kind of pockmarked and, full of burns all over the surface. So what these people have achieved is only destruction of the ovarian cortex. And what lies in the ovarian cortex is the follicles. Ever since we have AMH with us, we all know that each and every ovarian follicle is extremely precious. Even in a patient of PCOS who appears to have a lot of follicles, each of her follicle is precious. We are not out to destroy the follicles. So the key message here, which I want to give to each and every person, especially the juniors who are here listening to this, is that please don't target the surface of the ovary. Sometimes we may not have that drilling needle. Now, the drilling needle is 4 millimeter long. It is a monopolar instrument. Sometimes if you don't have that and you start just burning the ovaries with the monopolar hook, then all that you are going to achieve is the destruction of the stroma and the follicles, and your stroma is going to remain like that. You will never get the desired result. On the other hand, what happens if you go too deep? If you go too deep, then you are going to damage the medullary blood flow to the ovary. And once you reduce the blood flow to the ovary, it is definitely going to reflect in reduced ovarian reserve, and even in extreme cases, it can lead to ovarian failure. So you don't want to go too deep, but you don't want to remain very superficial. You want something in between where you're destroying the stroma, but preserving the cortex and the medulla. It's extremely important because now we are living in an era where we have the alternatives. Till maybe 3 or 4 years ago, we only had clomiphene. All of us know that 20% of the patients would not ovulate even with 200 mg of clomiphene. Even with extended clomiphene, they would not ovulate. But now that we have letrozole, we have got another option in our armamentarium, and most of the patients, they will respond to 5 mg, if not 7.5, they will definitely respond. So now, if you have clomiphene resistance in a patient, that means the patient is not ovulating with the highest dose of clomiphene that you give her, you have an option of letrozole. You can give her 2.5, you can give her 5, you can give her 7.5 also. More extended dose of letrozole I have personally not tried because I feel it is counterintuitive. It reduces the estradiol levels too much, even if you are able to get a follicle. But in my experience, almost 99% of the patients, they do ovulate with letrozole if you go up to a dose of 7.5 mg. So in my practice, at least since last 2 years, our need for use of drilling has drastically reduced. Earlier we were doing maybe 1 or 2 drillings a month, and now we probably do 1 or 2 drillings in a year. This has been the huge difference after letrozole has come in. Another option is metformin. So there are some people who would like to put a patient on metformin for 3 months. In my experience, it really works well with the lean PCOS. It is very counterintuitive because we feel that if the patient is obese, she is more likely to have insulin resistance and is better likely to respond to metformin. But actually, in our practical experience and even the evidence says that it is the lean PCOS who respond better to metformin. And of course, we have the option, if the patient is not responding to even letrozole or clomiphene, we can always do induction with gonadotropin. Most of you are ISAR members. Most of you, I'm sure, are familiar with the use of gonadotrophins. And, in expert hands, now that we have recombinant injections, we have pen devices where we can kind of calibrate the dose properly. We can always titrate the dose to get a monofollicular response. So still the indication remains clomiphene resistant cases, if they are not even responding to letrozole. It is always a second line option. I would really like to differ from the earlier discussion, which people said that, if the patient is not able to come for follow-up, or if there is endometriosis and you're doing a tubal evaluation for a patient with PCOS, you should drill simultaneously. The evidence does not support this. So you might do as a personal preference, but whenever we talk of evidence, there is absolutely no evidence that if a patient of PCOS is undergoing a laparoscopy for a tubal evaluation, she should undergo drilling. It is absolutely not indicated. Second thing, if the patient with PCOS is not able to come for a follow-up, this, in my opinion, is not an indication for drilling. That is because the recent protocol for ovulation induction says that you only have to call the patient once in the first cycle to confirm that she is ovulating. You need not call her for repeated visits. In our unit, the protocol is a single scan on day 12 to check for ovulation. If they ovulate, we send them home, and that's where they try for the next 3 to 4 months. So the conventional wisdom is rule of 4, so 4 punctures. The important thing is, what matters here is the length of the monopolar needle that you use. The standard monopolar instrument is 4 millimeters. However, if you happen to have a needle which is longer than 4 millimeters, then you have to reduce the dose appropriately. Don't use a very long needle because, as I said, it can damage the medulla and it can damage the blood supply to the ovary. There was a little bit of discussion regarding how to adjust the drilling according to the ovarian volume. Of course, PCOS patients comes in all shapes and sizes, and their ovaries as well. So you don't have a standard that, you might have a patient who has got a really huge ovary and she does not respond to 4 punctures. So what does the evidence say? This is an article from Fertility Sterility, adjusted thermal dose based on ovarian volume. Now, I could not find any papers on thermal dose based on stromal volume. And in fact, most of the evidence says that we have now stopped calculating stromal volume separately from the ovarian volume. So what it says is that the suggested dose was 625 joules per 10.8 centimeter cube. So that comes out to be 60 joules per centimeter cube of the ovarian tissue. And the dose which will be delivered in each puncture point will be 5 into 30, that is 150 joules. So you can increase or decrease the number of punctures depending on your ovarian volume. So it is always a good idea to check the ovarian volume. This has to be a transvaginal volume estimation, not a transabdominal one. So the number of punctures is equal to ovarian volume into 60 divided by 150. So this is a formula which all of us can kind of take home or kind of clip this slide, so that whenever you find that a patient of clomiphene resistance is having a high ovarian volume, we can use this formula. So if they say that compared to a fixed thermal dose, it is better to go as per the ovarian volume. Now, in between, there was some more discussion about unilateral ovarian drilling. So if you just drill one ovary, can you achieve enough stromal destruction to resume ovulation, and how does it affect the pregnancy rate? So this is another article from Human Reproduction 2013, and they said that there is a strong correlation between a larger right ovary and the success of ovulation regardless of the treatment use, and there is a strong negative correlation between the same thermal dose received by a smaller right ovary and ovulatory rate. So if you give a higher dose to the right ovary, it is supposedly having a better effect. Why this happens, they would not clarify in this, but they say that if you want to do a unilateral drilling, probably to choose the right ovary is a better idea. Now, this is a classic article by William Ledger. He has got a lot of landmark articles on ovarian drilling. This is a little older paper, but I thought that it is a very well conducted paper and all of us should read this. And they looked at various factors. They did a multiple logistic regression analysis and found out what are the factors which actually affect the success. So when a patient comes in, we know we have different PCO phenotypes. We have different biochemical parameters in each patient. So what are the parameters that predict the success? So in case the patient is obese, she is likely to respond poorly to laparoscopic ovarian drilling. This is very, very, very important. This is important because usually we will always correlate obesity with insulin resistance and high androgen levels. And we will be intuitively thinking that, okay, this patient is going to do better on drilling. But the fact is that the lean PCOS appear to do better when you consider drilling. Another thing is, longer the duration of infertility, the lesser will be the chances of live birth when this patient undergoes a laparoscopic ovarian drilling. Low basal LH levels, definitely they will have less response with LOD, and marked biochemical hyperandrogenism. This means that they will have lesser response to drilling simply because probably we were not able to achieve that stromal destruction enough to reduce the testosterone levels to resume the FSH and LH balance. So in case you have an older patient who is obese, who has a longer duration of infertility, probably it is a better idea to withhold drilling even if they are not responding to clomiphene. Now, how does drilling affect the menstrual cyclicity? In our unit, since many years it has been the protocol, in case we do a drilling, we ask the patient to maintain a menstrual calendar for next 3 months. If she has regular cycles, we will leave her alone for 6 cycles. We do not start inducing immediately after drilling. Now, what this again is a paper from the group of Dr. William Ledger. He found that almost half of the patients, even 3 years after drilling, had regular menstrual cycles. So while we all know that the chances of conception are the maximum within 6 months to 1 year, but it somehow appeared to improve the biochemical and the hormonal parameters, and almost half of the patients actually had regular cycles even after 3 years of drilling. So definitely it does produces a long-term improvement. It is not in all, it is in just 1/3 of the patient. And another side effect was that it does improve the acne and hirsutism. But there is a Cochrane review which says that you cannot use laparoscopic ovarian drilling as a surgical treatment for hirsutism alone in case it is not associated with a clomiphene resistance. Now, this is the paper, I think, which is kind of going to be the last nail in the coffin for laparoscopic ovarian drilling. It is very recent, February 2020. One of the researchers is Madeline Van Veli, who is also an editor for Human Reproduction Update. And this is a review which I think all of us must read, because what it tells you is that actually the chance of live birth is slightly reduced in ovarian drilling compared to medical ovulation induction alone. So this means that suppose the chances of live birth following medical ovulation induction with clomiphene is say 42%, the chances with laparoscopic ovarian drilling are actually lesser. It is between 28 to 40%. Unfortunately, the trials were having a lot of heterogeneity. There was also some selection bias in the trials, so that kind of downgrades the evidence, and they have put it as a low quality evidence. But look at the odds ratio. Odds ratio is 0.71 and the confidence interval is 0.54 to 0.92. So definitely laparoscopic ovarian drilling is not better than medical ovulation induction. It appears to be slightly inferior, but the evidence is limited by the quality of the trials. What it is better at slightly is the risk of multiple pregnancy. Suppose after clomiphene or letrozole, the multiple pregnancy rate is 5%. The risk with LOD is going to be 0.9 to 3.4%. So this we all know, because whenever we use any medical ovulation induction, the chances of multiples are there. So they concluded that actually laparoscopic ovarian drilling may decrease the live birth rate in women with anovulatory PCOS compared to medical ovulation induction alone. Maybe in the coming few years, as this review updates in the next 2 years, we will definitely find that the pregnancy rates are lower. And so it is high time, maybe not to stop doing drilling altogether, but to very, very carefully consider each patient of drilling that we do. Because definitely with laparoscopic ovarian drilling, there is less chances of OHSS, but all of us, we have been using now gonadotrophins for a long time. We know that absolutely there is zero risk of ovarian hyperstimulation syndrome with oral ovulations. Even with gonadotrophins, if you give a proper dose, if you use a chronic low dose step-up protocol, I don't think any of us have actually seen OHSS in medical, in gonadotrophin ovulation induction as well. So while LOD definitely gives you a monofollicular ovulation, but it reduces the chances of OHSS. Anyways, the baseline OHSS are going to be less in gonadotrophin induction as well if it is done by experts. There was no data which was available on medical multiple pregnancy. So the advantages according to this review were the one advantage which I feel is that it gives you multiple cycles. So with ovulation induction, if you give gonadotrophins, you have that cycle. But with drilling, patient can, you can leave her alone for 6 months, 8 months. So in my practice, at least, only the very young patients, the lean patients who have lower duration of infertility, less than 3 years, and who are not responding even to letrozole 7.5 mg are the only patients who get laparoscopic ovarian drilling. Disadvantages, all of us know. All of us have seen patients in our practice, all of us who practice IVF, we have seen patients with really reduced AMH. Drilling was done somewhere outside. And always the premise is the same. There are certain areas in my state where the surgeons are doing the laparoscopy for infertility. And surgeons being surgeons, they are so trigger happy, they cannot leave the ovary alone. Even if the patient is ovulatory, they will say ovary is looking cystic and they will do some chedchad, some drilling with the ovary. Even if the patient is anovulatory and she is undergoing a laparoscopy for some other reason, it is absolutely not indicated that you do a drilling, because the patient may be PCOS, but her ovarian volume may be say 9 or 10. And in this case also, because of the disadvantages and the reduction in ovarian reserve, it is not indicated. And this paper, I put it in the end because I feel it is very important. Whenever you do a laparoscopic ovarian drilling, there is a positive correlation between the AMH and the power Doppler flows before and after LOD PCOS group. So I feel that we all need to get together and do a proper multicentric trial on the role of AMH with the results in ovarian drilling. That is because now AMH we are doing liberally for all of the patients. Older papers, AMH was not that rampantly used. So I think
Dr. Priya, your time is getting over.
Yeah, this is my last slide, ma'am. So how to avoid reduced ovarian reserve, avoid cauterization at the hilum, please adjust the dose. And these kind of pictures where you can see the pockmarked ovary with burns all over the surface is absolutely not done. Never drill unless it is indicated. Individualize each case. It is probably now not the second line but the third line. Adjust the thermal dose if your patient is obese, prolonged duration of infertility, marked hyperandrogenemia, low LH level, she is less likely to do well with drilling. So my take home message is just one: be very careful when you are considering a patient for drilling. Even PCOS who are resistant, if they have some reason which would require IVF later, please don't drill, because you want as many follicles as you can get in IVF. Any patients who is planned for IVF does not need a drilling, and especially women with advanced age. So I think this is my last slide. Thank you so much for this patient hearing. I would love to have any questions if there are.
Thank you, Priya, for that very precise review of laparoscopic ovarian drilling. Now, we have any questions? Questions from...
No, questions will be at the end of the session.
At the end of the session. So thank you, Priya. We'll move on to the next speaker, which is my dear friend, Dr. K.U. Kunjamurthy, who's just across the Western Ghats from here. And he's an MBBS from Government Medical College, Thrissur, MD and DPNB from JIPMA Pondicherry, gold medalist in MD, advanced training in laparoscopy from France, training in ART, NUH, and worked as a chief consultant at Maulana for 21 years, at which time we were associates, and chief consultant at ARMC Kozhikode since 2009, founder and managing director of ARMC Networks in Kerala, Karnataka, and Tamil Nadu, chairman ARMC Aegis Hospital, Perindalamanna, visiting lab surgeon at Belhul Hospital, Dubai, and visiting fertility specialist at Nova, Qatar, visiting consultant IVF specialist at Modern Al Salma Medical Center, Oman. And his areas of interest are ART and laparoscopy. Is a joint secretary of IFS and Preston Pendelmana ONG Society. Dr. Maylene, over to you. Yes, Dr. Maylene.
Yeah, just sharing. Yeah, you can see my screen, right?
Yes.
Yeah. So, good evening to all. At the outset, I express my sincere thanks to Dr. Sanjeev Reddy, sir, for giving me this opportunity. And I congratulate sir and TAPISAR team for the effort in the webinar series. Respected Chairperson, Dr. Kannagi, Madam, at this outset, I'm very happy to see you because Madam has helped me to start our IVF center way back in 2005 at Maulana Hospital. And the topic for the discussion is how to prevent OHSS in PCOS. Any discussion on PCOS, we cannot conclude without mentioning OHSS or multiple pregnancy. So that is the two most important things which we fear, or two most important complications which we fear when we treat polycystic ovarian syndrome, either with ovulation induction or during controlled ovarian stimulation for IVF cycles. So what is OHSS? It is an iatrogenic complication of controlled ovarian stimulation, and it is needed for controlled ovarian stimulation is needed for production of multiple ovarian follicles to retrieve the number of oocytes. But OHSS, however, is characterized by an exaggerated response to this process of the ovarian stimulation. The incidence of moderate to severe OHSS is between 3.1 and 8% in IVF cycles, but can be as high as 20% in high-risk women, that is in PCOS. And PCO women are considered as the most important high-risk factor for the occurrence of ovarian hyperstimulation syndrome. And it has been documented to arise spontaneously either in conjunction with clomiphene or with gonadotropin use. So the PCO, the one thing which we very often come across during conventional ovulation induction is that sometimes that PCO ovaries may not respond to your clomiphene or oral ovulogens, but sometimes it may respond enormously, causing an OHSS in that even during the CC cycles. So there are 2-3 different types of OHSS. I just want to quickly run through the initial introduction part before going on to the proper preventive strategies in PCOS. So there is mild OHSS with abdominal bloating and mild abdominal pain, and ovarian size will be large, but it will be definitely won't be that big, will be often less than 8 centimeter. And there is moderate OHSS, that is with moderate pain, with nausea and vomiting, ultrasound evidence of ascites, and ovarian size usually 8 to 12 centimeters. Other strategies, pre-solve strategies, we never come across the severe type of OHSS, or rather we all have learned to have an OHSS-free clinic. The severe OHSS, clinical ascites, occasionally pleural effusion, oliguria with hemoconcentration, and ovarian size, it will be very large, and you can see a lot of redundant follicles, and it will be most often more than 12 centimeter each ovaries in size. And there is critical OHSS where there is dense ascites, hematocrit PCV will be too much elevated, there will be leukocytosis, oliguria or anuria, and thromboembolism and acute respiratory distress syndrome. Way back in 2005-2006, we had a patient with a severe OHSS. She has been tapped for several occasions of ascitic fluid tapping. She was on thromboprophylaxis and all other supportive measures, and she has developed the hydrothorax. And we have aspirated the hydrothorax once due to relieve the respiratory distress. But unfortunately, because she was on this thromboprophylaxis, she had bleeding from that, the hydrothorax puncture area. We had to do thoracoscopy and cauterize the wound. She had an arrest on the table, but was revived fortunately. But these type of severe situations, we never come across in this present era of ART. So this is the pathophysiology. We all know HCG will trigger or activate the RA system, increase the VEGF-A. increases vascular permeability, and that will result in fluid extravasation and all the eventualities of an OHSS. So that is the pathogenesis of OHSS in PCOS. There is large cohort of follicles developed and sustained following the ovarian stimulation. And unfortunately, earlier days, because of the agonist cycles, we have only way to give HCG. So the administration of HCG, that leads to massive luteinization and overproduction of VEGF, dysfunction of blood vessels, massive fluid shift, and resulting all other clinical parameters of OHSS. Can result in early, that is late OHSS, and the pregnancy is the most common result. And this factor, this late OHSS, even at present, in this present era, when we do most of the fresh transfers, we can have this late OHSS in with antagonist cycles as well. So that is the classical biochemical and clinical features. And the prevention is always better than cure. So now we are going to, what are the strategies? In short, we'll go across quickly in next 12 minutes. So being aware of the risk factors, that is the most important thing to prevent the OHS, and that will allow the clinicians to predict its occurrence and so reduces its incidence during ovulation induction with the gonadotropins. And we have primary and secondary risk factors. Here the primary risk factors, of course, PCOS and PCOS in a young age, and again lean PCOS, previous OHSS history, and the excess level of AMH and the AFC, huge number of AFCs, that itself all will categorize into PCOS. But PCOS who are at young age and low body weight and previous history of OHSS, they are very prone for a further incidence. And during stimulation, you have to notice that there may be a rapidly increasing estradiol level. There may be a large number of developing follicles on the day of HCG administrations. What we generally land up in trouble is on 5th day or 6th day, or even on 7th or 9th day, we see a cohort of follicles, which we are maybe only one follicle, maybe 17 millimeter. You may see lot of follicles at 14 millimeter, 13 millimeter and all. So you leave alone that 17 and you go for this 14, 13 and all, and you stimulate further. So this patient will definitely land up in ovarian hyperstimulation syndrome if the precautions are not prompt. And none of the above predictors are independently predictors of OHSS in PCOS patients. So this is the one situation I just mentioned. Sometimes you may see one or two dominant follicles, but all other follicles may be around the range of 14 or 13 millimeter, or maybe even 15 millimeter. And you may go for that, the second cohort, and you will land up in trouble. And AMH, high AFC, and the development of more than 25 follicles is estradiol of more than 3,500. And when the oocytes retrieved are more than 25. And these are the cutoff points of our OHSS risk. And what is the primary prevention? So in conventional ovulation induction, we have to aim for unifollicular ovulation, that is follicular development, maybe 1 or 2 follicles in PCOS, and individualize the stimulation regimes. Alternatives for triggering ovulation. Sometimes on 14th day, 15th day, you may see a follicles, some 3 or 4 follicles may be there, which are not of good size. Patient may not be willing for taking further gonadotropin to accelerate the growth or something. You may leave the patient alone, but maybe a 28th or 29th day, she may have spontaneous surge and she will come back to you. The pain, cyst, and fluid retention, all those things may be there. So these are the situations where we neglect the risk factors and we land up in troubles. And avoiding HCG for the luteal support, that also is very important, especially in conventional ovulation induction. How can we achieve unifollicular ovulation induction? Reducing the gonadotropin dose, GnRH antagonist even in the conventional cycles, adjuvant metformin therapy, and aromatase inhibitors. Use of aromatase inhibitors, that also is a very good option in this group of patients. Reduce the gonadotropin dosage. And in controlled ovarian stimulation, the minimum gonadotropin dose should be used for ovulation induction given its low risk of OHSS, and this favors a step-up regimen over a step-down regimen. In the step-up regimen, ovarian stimulation is initiated with a low dose of FSH. And see, these type of stimulations, it will take longer number of days, and you have to really counsel the patient. Otherwise, the patient may drop drop the stimulation cycle. And this dose is then continued until the criteria for ovulation trigger is met. Then GnRH antagonist protocol, that is the biggest advantage of the antagonist cycle to prevent the OHSS incidence. It has totally eliminated, almost to the tune of nearly 99 to 100%, it has eliminated the occurrence of OHSS in the present day IVF clinics. This allows less gonadotropin use than agonist protocol and also less days of stimulation. That's not most important. This allows avoiding HCG for ovulation triggering. That is the point which prevents the OHSS. And this protocol has lower risk of OHSS and multiple pregnancy and is cost effective. And metformin. Can metformin reduce the incidence of OHSS? It's a long time debate. It exerts in its influence in preventing OHSS by inhibiting the secretion of vasoactive molecules such as VGF during ovulation induction, so modulates vascular permeability. In the recent Cochrane review by So et al., it was noted that there was a low risk of OHSS with metformin use. Reduce the risk of OHSS by 63%, increase the clinical pregnancy rate without the effect on live birth rate. So a daily dosage between 1000 to 2000 milligram at least 2 months prior to controlled ovarian stimulation is recommended for the purpose of preventing OHSS, which we may not get that much time during the IVF cycles, because most often the patient will land up just on the day 2 to start an IVF cycle. We may not get sufficient time to prime the patient in most of the situations. Then aromatase inhibitors, a recent Cochrane review by Franek et al. Failed to show any difference in OHSS rates through utilization of aromatase inhibitors in contrast to other methods of ovulation induction. And letrozole can be used in luteal phase in freeze-all cycle to decrease the incidence of OHSS, but little evidence available. There were few articles which I have come across when during the controlled ovarian stimulation cycles, if you put the patient on letrozole 2.5 milligram TID for 5 days from day 7 of the cycles, it may reduce the estradiol value and may reduce the OHSS incidence, but it doesn't have much statistical significance as per the further studies which have been reported. So the individualized controlled ovarian stimulation, one example of this can be seen through the study of Lamarca, where an algorithm was formulated based on the AFC FSH to calculate the FSH starting dose. You all might be remembering that pyramid type nomogram, where you can calculate the FSH dosage based on AFC, AMH, body weight and age as well. This may be a little useful to calculate the proper starting dosage. Alternatives for triggering ovulation. The agent of choice for triggering ovulation should be picked based on the risk of women developing OHSS. Even in PCOS patients, if the follicles are in optimum number, need not go for agonist trigger. But whenever you suspect an OHSS scan or the estradiol level is high, you can very well use the agonist trigger. In my practice, I generally use a decapeptyl 0.2 milligram for triggering the maturation. And exogenous HCG, its long half-life, however, causes prolonged luteotropic effects, multiple corporal luteal development, and higher luteal phase progesterone and estrogen concentration. There is a high risk of OHSS, and to solve this problem, the lowest possible dosage is 5,000 and avoid HCG in high-risk women. And that's what we are keeping on telling. And the dual trigger and the supporting the luteal phase cycle, all this can increase the incidence of OHSS. And it's always better to avoid. Give an agonist trigger and a freeze-all strategy will be much better. And agonists produce more tempered and shorter mid-cycle gonadotropin surge in contrast to HCG. And this LH set should be sufficient to induce ovulation without being prolonged enough to induce the hyperstimulation. And OHSS is virtually eliminated with agonist utilization, but in conjunction with a freeze-all approach, which should be considered in high-risk women, and this is called OHSS preclinic concept. And there is a good evidence that live birth rate is lower in fresh cycles following agonist trigger, and the mechanism for this is rapid and dramatic drop in hormonal LH support as compared to HCG, and poor final oocyte maturation may be happening. And how to improve live birth rate with agonist freeze-all embryos, that's the most important strategy, which is easy to apply with a good freezing program and TOG program in your IVF lab. Co-trigger with the 1,500 units of HCG, either single dose can reduce the risk of OHS. But I feel in many of the studies, you can see a lot of reports from Peter Humaydan that the dual trigger that will not eliminate the risk of OHSS. And recombinant LH, it has a half-life of 10 hours. And Cochrane review, however, did not show any difference in the risk for severe OHSS between the recombinant LH versus the urinary HCG. And also it is associated with lower pregnancy rate and poor cost-benefit ratio. Avoiding HCG for luteal support, that is another strategy. And in contrast, the use of progestins have the OHSS risk while significantly improving the live birth rate and avoiding the risk of OHSS. The routine use of progesterone over HCG is recommended for the luteal support. What are the secondary prevention strategies? This can be costing, it can be cryopreservation, it can be cycle cancellation. So the first thing about costing, and the costing is a preventive strategy by which gonadotropins are withdrawn wherein certain E2 concentration or critical number of follicles are reached. And HCG trigger is subsequently given. Once the E2 reaches a safe level, HCG is administered followed by oocyte retrieval and embryo transfer or freezing depending on the E2 concentration. These are the disadvantages. It is generally employed for a period of less than 3 to 4 days. Costing is commonly used as a first-line secondary prevention strategy. And actually, costing was of significance during the agonist era, but not during the antagonist era. And it does significantly decreases the oocyte quality, the number, and the fertilization rate, and the cleavage rate. The granulosa cells aspirated from costed patients showed a ratio in favor of apoptosis, especially in similar follicles. And what happens when you start costing, when the lead, see, ultimately, even though estradiol value goes down and you wait for the estradiol value to come down to a safer level to give the HCG, but ultimately it ends up with a lot of problems like occasionally E2 drops markedly to very low level and cycle has to be cancelled. Difficulty in identification in oocytes in aspirated follicular fluid after prolonged costing. Pregnancy rates appear to decrease while costing during prolonged gonadotropin-free periods. And explanation for lower birth rate is because of suspending gonadotropins may starve the granulosa cells at a critical time of oocyte development, and that is necessary. Why I was showing costing few slides is mainly because it is a very common trend in the junior people who are doing IVF cycles. As soon as they see a little bit of OHSS, more number of follicles tend to have OHSS, they immediately go for costing, because when I come across our discussion with many of the juniors, they have a tendency to do the costing, but they have to understand that costing has not much of significance in this present era. And cryopreservation of embryos is another secondary prevention strategy, and because of the very good vitrification methods and thaw rate, it is one of the most accepted thing along with the agonist trigger. And recent evidence, however, strongly supports the use of agonist trigger followed by cryopreservation as being the most effective method in preventing OHSS in PCOS patients, best illustrated by DeVroy and colleagues through their OHSS preclinical concept. And the problem with cryopreserved embryos was the lower pregnancy rate in contrast to fresh embryo transfer related to older slow freezing methods. But we have now very good vitrification methods that will bypass all these difficulties. Cycle cancellation is the last thing which we have to resort, because that will really affect the patient's financial and as well as the psychological status. And there are a lot of alternative things like cabergoline, giving high protein IV fluids, IV calcium, aspirin, vasopressin, IVM. So cabergoline is one thing which needs some discussion. And it's a dopamine antagonist which prevents the excessive increase in VEGF mediated vascular permeability encountered with OHSS through its anti-androgenic properties. And this protective effect, however, did not extend to severe OHSS, possibly due to the number of studies available in comparison. Use of cabergoline is recommended. It is suggested that the treatment to be commenced on the day of HCG trigger at a dose of 0.5 milligram for 8 days. So that is the recommended regime. And colloid infusions, of course.
We have exceeded the time. Can you just wind up?
Yeah. The albumin, high protein infusions, calcium, aspirin, IVM, in vitro maturation, that is one thing. So to conclude, these are the final thoughts. OHSS is iatrogenic problem, what we create. It occurs when HCG is given. Prediction and prevention should be always our goal. Step-up protocol is better than step-down. Antagonist protocol is better than agonist. Metformin should be given for all PCOS patients if deemed fit. And agonist is better for, the NRH agonist is better for ovulation triggering, but sugar to dose HCG or freeze all, and costing needs more research, and it is not as significant as before. And cryopreservation is recommended for high-risk patients. Cycle cancellation is the last resort, and cabergoline can be recommended for prevention of mild or moderate OHS, and it is a self-limited condition. With this, I conclude. Thank you. Thank you for the patient hearing.
Thank you, Dr. Moideen. That was very comprehensive. And we'll move on to the next speaker, Dr. Shagun Agarwal, who will be talking on, her deliberation will be on genetics in PCOS, probably the way the PCOS will be looked at in the next few decades to come. Dr. Shagun Agarwal, she's an MD-OG with a DM in medical genetics, and her current designation is an associate professor in the Nizam Institute of Medical Sciences, Department of Genetics, adjunct scientist, Center for DNA Fingerprinting and Diagnostics. Got several research papers in index journals and written several chapters in books, and associate editor of the Genetic Update for the Next Generation Clinician. Her professional achievements are discovery of novel genes causing human phenotypes, and conceptualized and started MSc Genetic Counseling program at the Host Institute, coordinator of the CMG Clinical Genetic Fellowships at Genetics Telemeeting, executive committee member, Indian Academy of Medical Genetics and Society of Fetal Medicine, DHR short-term fellowship recipient in 2018, and holder of 3 research grants. Research interests are genetic characterization of fetal malformation syndromes. And there you have this Dr. Shagun Agarwal going to speak to us on the genetics of PCOS. Over to you, Dr. Shagun.
Thank you. Thank you, madam. Good evening, everybody. So at the outset, I would like to thank the organizers for inviting me to be part of this program. So my talk is going to be very short and very clinically oriented. I'm not going to take you to some theoretical aspects of genetics of PCOS. So I'll be starting my screen sharing now. Just a moment. I hope my slides are visible.
Yes, visible, Dr. Shagun.
Thank you. Thanks, madam. Okay. So what I'm going to cover is basically the genetic aspect of PCOS with regard to 2 main categories of disorders. So some of the PCOS can actually be pure genetic disorder actually, or which is what we call as single gene disorder or monogenic disorder or Mendelian disorders. So these in turn can be, some can be syndromic forms. So where besides PCOS, the patient will actually have many other features. So if in the clinic, if you see a patient with PCOS who has these other associated features, then you should, it should, kind of raise an alarm that, okay, this is a patient who has a syndromic form and a genetic condition, and PCOS is part of that. So that is one group. And then the other, there are also some non-syndromic forms of single gene based PCOS. So there are no, the patient presents like a classical phenotype of PCOS, but actually it is a single gene disorder or a genetic disorder. So this category is actually extremely rare in the, in PCOS patient overall. So most of PCOS has a genetic aspect, but it is actually not really, the genetic aspect is not very, very strong. So most PCOS is actually polygenic or multifactorial. So, so what I'm going to try to, through this talk, what I'm going to just kind of emphasize is that whether we should be doing any genetic test in PCOS in the clinic, and does it help us in any way in diagnosis, management? And is there any specific type of PCOS where this kind of genetic evaluation should be done? And then what kind of test should be done? Okay, so it's very clinically oriented kind of a presentation. So this, I'm sure everybody is familiar. So the PCOS definition has evolved, and we have the 4 main phenotypes now described. And we all know that there are basically 4 different kind of pathophysiology. One is at the level of the insulin resistance and hyperinsulinemia. One is hyperandrogenism and the follicular arrest happening in the ovary. And then we have the problems in the neuroendocrine axis whereby there are abnormal gonadotropin levels. So these are the main kind of 4 pathophysiological mechanisms and ongoing in the body, and we all know that they are all kind of influence each other. And then depending on which pathomechanism is more predominant in that patient, we have these 3 or the 4 different phenotypes: the classic, which includes A and B, and the ovulatory and the normoandrogenic phenotype. So depending on which axis or which component of the PCOS pathology is more prominent, we have the different phenotypes. So if we try to see what is the evidence showing that there is some kind of a genetic influence to PCOS, we see that there is actually, if we look at, so one of the ways to study this is actually what is called as twin studies. So between dizygotic and monozygotic twins, is there a difference in incidence of PCOS? So all those kind of studies and many other studies have shown that at least PCOS has a genetic component is quite significant, and 70% of PCOS is kind of heritable or is influenced by the genes. And then there are many families where you would have multiple family members with PCOS. But does this mean that PCOS is a genetic condition? Not really. So what if we look at any disease and see that, try to classify, is this a genetic disease, is this an environmental disease? So actually many diseases would fall into this spectrum kind of a thing, where both genes and environment have a different degree of role to play. So if we pure genetic disorders or monogenic Mendelian disorders, if we take an example, so these would be like congenital adrenal hyperplasia or androgen insensitivity syndrome. Whereas in between you would have conditions like PI, gestational diabetes, where genes and environment together influence the disease manifestation or the phenotype. And on the extreme end, you have genital tuberculosis, is basically an environmental disease, or an environment plays the major role, and genes don't have much of a role in the disease. So, so when we say the pure genetic disorders, actually what happens in these conditions is that you have a genetic defect, which is extremely rare. If you look in the population, very few people will have that defect, but whoever has it has a very high penetrance, means that person will surely get the disease. That is a pure genetic disease. And on the other hand, you have conditions like PIH and gestational diabetes, where these people will have a genetic variant, but this will be a very common variant, means 0.1% of 0.1 people, I mean 1 in 100, at least 1 in 100, sometimes even 1 in 10 individuals in the population will have that variant. So it's a very common variant, many people have it. And then some of these people will go on to develop PIH and gestational diabetes, depending on the coexistent environmental contribution. And then, and of course, conditions like genital tuberculosis, the contribution of genes is quite less. So these rare variants are what is called as mutations, and these common variants are what we call as SNPs or polymorphisms. So this, like I have said it in the previous slide also, so a monogenic disorder is where you have a genetic defect that's called as a mutation. Everybody who has a defect gets the disease. Whereas in a PI condition complex or a multifactorial or a polygenic disease, there are multiple different variants in different genes, and their contribution to the disease is again different in different people, different population. And there is also strong influence of environment and lifestyle, but you would see a familial clustering. And then it is basically because these people in the family have these variants which they share, or these polymorphisms which they share, which kind of shifts their susceptibility to the disease, the curve towards the right. So they are more at risk of disease as compared to somebody who doesn't have that variant. So that is the reason why there is a familial clustering. So where does PCOS fall? Is it a monogenic disease? Is it a multifactorial or a complex disease? So as I said earlier, most of PCOS is actually multifactorial. Genes play a relatively small role, but we have a category of PCOS which is purely genetic. So now let me, this picture is just showing again the different components which are involved in pathophysiology of PCOS, and then which are the genes. So they could be genes involved in the hormone synthesis, genes involved in the hormone action, or genes involvement in insulin action and secretion, and various other genes which are known to contribute to PCOS. So first, let's look at genes involved in ovarian and adrenal steroidogenesis. So in each of this category, actually, there are some monogenic forms and some the multifactorial forms. So let's see a case now. So this is actually a lady who was 21 years old and married, she was conceived of a consanguineous couple, and then she at birth itself she had some clitoromegaly and some excessive pubic hair, and then since 10 years of age she started having some virilization and had precocious puberty at 10 years, and then also had a surgery for clitoromegaly at 12 years of age. And then on examination, they were essentially unremarkable. Her karyotype was normal. And on ultrasound abdomen, she had a PCOS phenotype. And then you can see now her hormonal profile. So she had increase in androgens. And then she also had an elevated 17-hydroxyprogesterone. So actually, this was a case of a classic but simple a classic non-salt wasting kind of congenital adrenal hyperplasia due to deficiency of the 21-hydroxylase enzyme. So we all are familiar with the classic phenotype of the congenital adrenal hyperplasia, whereby a female child is detected to have genital ambiguity at birth. And many of these children would also have a salt losing crisis, and they may even die in the neonatal period. This is a classic phenotype of congenital adrenal hyperplasia. But then there are also milder phenotypes where the enzyme deficiency is not that severe. So a slightly milder phenotype will have ambiguity or some virilization at birth, like this girl. So she had some clitoromegaly right at birth. But these children will not have salt losing, and then they go into precocious puberty and then a PCOS kind of phenotype. So this lady actually fitted into that. So we went ahead and confirmed that she indeed had a mutation in this particular gene, CYP21A2, which causes congenital adrenal hyperplasia. So like I said, so there are basically three types. So this is the classic type which we are all familiar with, a child at birth itself, a girl child presenting with genital ambiguity and having salt wasting. But then we have the simple virilizing classic form, which is what this lady had actually. So these can have varying degree of genital ambiguity, have virilization and precocious puberty and a PCOS phenotype. And we have an even milder phenotype where the enzyme deficiency is not that severe. So these actually can present like a typical PCOS patient. They will not have any ambiguity. They will just come to you like a PCOS patient. But it is important to pick these ones up because the treatment is very different from what is a conventional treatment of PCOS. So actually there is data which says that 2 to 10% of women with hyperandrogenism actually have this non-classic type of congenital adrenal hyperplasia. And then these women don't have any ambiguity, no salt losing crisis. But if you do a simple 17 OHP level, you'll find it more than 2 nanogram per ml. And then if you treat them with corticosteroids, their ovulation gets restored, the PCOS disappears, and then they can conceive. So the treatment, it is very important to recognize, and in fact ACOG recommends that we should test all women with PCOS with just for this particular condition, because it's quite common and the treatment is different from the regular treatment for PCOS. So besides this 21-hydroxylase deficiency, which is the commonest cause of congenital adrenal hyperplasia, these are the various enzymes, the three which I have highlighted, which can also cause a similar presentation, and they can be recognized if we do certain urinary steroid metabolized or by further molecular testing. And then again, these patients respond to corticosteroid, or sometimes they may even need a mineralocorticoid treatments, as happens in 3-beta-hydroxylase deficiency. But these all other three conditions are quite rare, so routine testing is not recommended. Routine testing is warranted only for the 21-hydroxylase deficiency. So besides this monogenic form of the adrenal or the steroid genesis pathway causing PCOS, we have polymorphisms or SNPs in various other genes which are part of the steroid biosynthesis pathway. But clinical testing for this is not really recommended. So then we go on to the next group of genes. These are the genes which are involved in insulin action or secretion. So insulin gene or insulin receptor or other downstream genes. So here let's again see a case. This is a case I've taken from literature. It's a very rare condition. So this actually is a 13-year-old girl presented with very severe acanthosis nigricans, as you can see, and also had diabetes, some facial dysmorphism and PCOS and a loss of subcutaneous fat. So actually this is a case of a condition called as Rapson-Mendenhall syndrome, and this is caused by mutations in the insulin receptor gene. So because of this mutation, these individuals have very high insulin resistance. So this manifests basically as a very early onset diabetes, and then later on some of them can go on to develop a PCOS phenotype also. So, so this particular phenotype, which I just showed the patient, Rapson-Mendenhall syndrome, so this can kind of present as a syndromic PCOS. So you have a relatively young, where the PCOS phenotype starts very early, and you also find that the child has having so many other findings. You have dysmorphism. They will also have some failure to thrive. Also, some of them may have intellectual disability. Also, there would be other symptoms besides the PCOS. But the same gene, actually, the mutations in the same gene, insulin receptor, can also cause type A insulin resistance and acanthosis nigricans.
Your timing is nearly for 3 minutes more.
Okay, ma'am. Yeah, okay. And then the thing is that to recognize this group of disorder is important because we can treat them with these different compounds, what I mentioned here. So then there are also various SNPs reported in the insulin gene and the other genes in this pathway. So then we have another group of disorders which actually quite mimic this insulin resistance group of conditions. These are the lipodystrophies. So this is a child with congenital generalized lipodystrophy, also known as Berardinelli-Seep syndrome. So you can see the features, various features are there. Main thing what you can make out is that very muscular appearance. Look at her face. Look at these muscles here. So it's a very muscular appearance, and they also have hypertrichosis. There are so many different genes which can cause this kind of a lipodystrophy phenotype. So these are conditions with basically abnormal adipocytes presenting with insulin resistance, again PCOS, but additional findings, dysmorphism will be there. Diagnosis by molecular testing and treatment here is leptin actually. So again, you can recognize these patients because they will have so many other findings. And then we can have mutations in the gonadotropin action regulation. So these are some recent papers, actually the same group, which reported that 6.7% of women in the European population with PCOS actually had a mutation in the AMH or an AMH receptor gene. But this is very like the preliminary study and only for one population. So we don't really recommend testing for this. And then there are also various SNPs associated in the various gonadotropins and their receptors, which are known to be associated with PCOS. So besides the genes which I already showed, at least these are the various other genes which are known to have SNPs and show basically increase the susceptibility of PCOS. But what we need to remember is that these SNPs or polymorphisms increase the risk very slightly. So maybe 1.5 to 2 times also sometimes the increased risk is there. But there is no recommendation for doing clinical testing for any of these SNPs because it does not change your treatment. So what should we be doing in the clinic? That's all what is important for us as clinicians. So all patients of PCOS should undergo a 17 OHP level. This should be done in the morning, in the follicular phase. So more than 2 nanogram per ml, then in case the patient has this value, then you go for an ACTH stimulation test. If it's more than 10 nanogram per ml, then your diagnosis is confirmed that the patient is more or less confirmed. Patient has a non-classic form of congenital adrenal hyperplasia. Then you should do a molecular testing to confirm your diagnosis for sure. And then you can start these patients on corticosteroid treatment. And this can help. Identification of this would help the patient, and their sibling her sisters may also be having the same condition. So you can identify them and then you can offer treatment to them also. Then besides 17 level, yes ma'am, I'm done. Yeah, this is my last slide. I'm done. So this besides doing a 17 OHP level for all non-syndromic PCOS, we should assess all patients to look for any ambiguity, and if there is ambiguity, do a karyotype. And then besides this, also if additional features are there, we can do urinary metabolites for steroids, other steroid biosynthesis defect. So if you have genital ambiguity, basically, then these two things need to be done. And if there are associated things like dysmorphism, intellectual disability, lipodystrophy, it's better to refer to a medical geneticist so that then we can assess whether the patient has a lipodystrophy or an insulin resistance syndrome, and we can confirm it by molecular testing, and then these patients can be helped by the specific treatment for this group of disorder. At present, there is no recommendation for testing for AMH or the receptors, and no testing is needed for the common variants or the SNPs. So finally, just to conclude, so PCOS in the majority is a multifactorial disorder, and there is effect of multiple genes, but the impact of those genes is less. Only a few patients may have a single gene disorder, but it is important to recognize them so that you can, the treatment of these patients can be more optimized. So with this, I would like to conclude. Thank you.
Thank you, Dr. Agarwal. That was a very good insight for us gynecologists into the genetics, and I hope we'll be going.
Thank you, madam. Thanks.
I don't know if there's time for more questions. Dr. Reddy?
Yes, you can start asking now. There is one question they posted.
For some comments on Dr. Moideen's talk, or rather I would ask him a question. Do you rely on your E2 levels for during your ART cycle? Do you do regularly?
No, we don't do regularly the estradiol monitoring. Only thing is that at the time of ovulation trigger, if we have any doubt that it is not OHSS or maybe some this side, that side, only in that situation we do estradiol monitoring. Otherwise, we generally won't do.
Okay. The second question, the second comment I would like to say just for everybody is the type of follicles you see decide the size of the follicles, decides whether it's minimal, you're going to land in minimal hyperstimulation, moderate, or severe. If you look at the ovary with plenty of big follicles, mature follicles, very unlikely you're going to get into a severe hyperstimulation. If you see a huge population of intermediate follicles, then you're likely to get into a moderate hyperstimulation. And if you see very few moderate or big follicles, but a large number of small follicles, this hyperstimulation is going to be severe. This is a rough guidance when you're stimulating. And as you rightly mentioned, segmentation of the cycle into giving the antagonist, like what Dr. Negori had illustrated, practically makes it an OHSS-free clinic. And for that, you need to have excellent vitrification facilities, and you must counsel the patient ahead of time regarding the risk and the need for segmentation and vitrification. And any other questions from the panel? I don't see any questions from the audience. And
two questions are there.
Yeah. So one is, to all the PCOS patients.
Do all the PCOS patients have genetic problems? If so, why increased incidence of PCOS recently? Dr. Chandra Ponuswamy.
Okay. Okay, so I tried to show through my presentation. So all patients will may have, quite likely they may have a genetic predisposition. Predisposition is just like diabetes or hypertension. So there may be some polymorphism or a genetic kind of a defect, which is not even a defect, it's a variant. So like I said, 10 to 100% normal people will also have the same genetic variant. That is why we call it as a polymorphism. So that will be there in probably most likely all patients with PCOS, which increases the risk of developing PCOS. But it is actually the environment after that which kind of really leads to the disease actually coming forth. So the increase may in recent times, like what you have asked, is probably more likely that the environment has become, like with the new lifestyle, the environmental predisposition or that component has become more prominent. So the genetic variants are there. They have been there since beginning itself, but it's the environment in which is now causing, coming together with that to result in the disease. So that's probably the cause why the increased incidence is there.
Dr. Agarwal, on the same note, looking at the environment and PCOS, excessive food intake, obesity, yes, may relate to PCOS, may be the epigenetic transformation.
Yes, ma'am.
opposite, exactly the opposite. During starvation periods, it is a response of protection of the reproductive capability. The follicles increase. Is that, I remember reading an article, but I'm not able to quote the exact thing, is something which happens in animals and is the same thing reflected in the thing. It's a protection mechanism when there is starvation of whatever. Is it so?
As far as, yeah, ma'am, what I think what you're referring to, I'm not sure like what exact paper I mean you're referring to, but what we know is that there is this hypothesis, like when there is a starvation of the mother during like a lady when during the pregnancy, so that time it's the baby actually which develops all these kind of mechanisms. These are all epigenetic influences only. So actually environment influences our gene through various epigenetic mechanism. So it's the mother's starvation which kind of leads the baby to a kind of changes in the body physiology, whereby it says that we need more food or more those kind of pathways get activated. So these children subsequently develop all these metabolic syndromes. So all these things come up. So diabetes, hypertension, that central obesity and PCOS phenotype. So that is the mechanism which happens. That is known. There's a name, Barker's hypothesis. Yes, ma'am. That's it. So that's the main thing there.
Any other questions?
Priya, Dr. Priya, can you?
Yes, sir. Yes.
Okay. See, we are facing some problem after following drilling. The ovarian reserve tests are normal, but if you stimulate, that patients won't respond. We are getting very few oocytes only. Do you face the same problem or you have a different thing?
So a patient who has a good antral follicle count and normal ovarian reserve is not responding.
No, definitely the AF count is decreased, but the hormone, everything will be normal for them. They're following drilling. Many patients, they are coming. So blood tests are normal, but if you do the AF count, that is definitely decreased. And if you stimulate also, they are not responding as though without drilling, the number of follicles what we are having, that way they are not responding.
I have a name for that. That's called the fried ovary syndrome.
Okay.
Where the patient goes to,
so next Nobel we may get to Coimbatore.
2 or 3 drillings, where the patient goes to 2-3 people, each one has a go at the ovary. And finally, that ovary is shrunken, AMH is low, and as you said, they will not even throw up a single follicle. Is that so?
No, I'm having different name for that husband syndrome actually. Most of the gynecologists' husbands are surgeons. They're only burning actually. It's not by the gynecologist. Okay. Kunjumayuddin, can you tell me, do you give any continuing of antagonist to prevent or high-risk patients for OHS? Can you continue for 4 or 5 days?
Yeah, yes, sir. We continue the antagonist in the same dosage, 0.25 milligrams subcutaneously for 3 to 5 days.
So with that, actually, we can make it 0 actually.
Actually, that's a very effective drug for bringing down, it almost brings down the risk practically to 0.
Vijay, you want to ask anything, Dr. Agarwal? You want to add anything, comment something?
Sanjeev sir, regarding your question, I think what is happening nowadays is whenever the people are drilling, they are damaging the surface more. So all the cortex goes off and the stroma is still there. Now AMH is going to reflect pre-antral as well as antral follicles. AFC is going to represent the antral follicle. So that is why these women may have normal AMH, because they may have a good pre-antral pool which is not visible on ultrasound. But ultimately the follicles which will be recruited are those which are in the antral pool, which is already reduced because of the drilling too much of the surface rather than targeting the stroma. So that's why probably they don't respond that well to drilling.
Then what trigger you are giving usually for these patients? Unmute.
Agonist trigger with decapeptyl 0.2 milligram.
Will you give single dose or 2 doses?
Yeah, single only, sir. Single only.
Many times, if you give single dose, they will have many immature oocytes already there.
Generally, I found the oocyte recovery percentage is quite satisfactory.
There are two ways. One is like after 8 hours or something like that, 10 hours, you have to estimate the LH. Somebody was telling Nagori or somebody
there are few
is
articles
15.
like that, but generally,
So we also had some problem in the beginning, sometimes when we are giving. So instead of that one, we after 12 hours, we are regularly giving second dose. Suppose if you are giving a leukocyte state, 2 milligrams in the first time, then I'm giving 1 milligram that after 12 hours. Then there is no problem at all, this problems. So there's no need for us to estimate the LH other things.
If you give the second dose after all, when do you time the aspiration, follicular aspiration?
No, with the first dose only 34, actually 2 hours earlier we'll do like in this. So around 34 hours we'll retrieve. Second dose, from first dose onwards, we have to take 34 hours.
Okay.
So this problem is gone. So these patients will be having main other problem is asynchronicity, follicles. Anything you are doing to synchronize the follicles? Priya also you can share, Dr. Kannagi also you can share your opinions.
Usually, if there is an asynchrony, you just see, you divide them into 3 groups. The ones which are leading, which may be only 2 or 3. And the second group may be larger, larger numbers, but somewhere 2 or 3 millimeters less. So you target the second group rather than the first group. You may let the first overgrow a little. You may get just, fluid from them. You may not recover a proper oocyte, but then you get a larger number of mature oocytes from the second group. That's one thing, how you deal when you have a growth which is not a cohort.
Dr. Kannagi, there are 2 questions are there in the, just you can check.
Yeah, wants to say something?
No, there are 2 questions are posted now, just you can ask them. 2 more questions are there in that.
Yeah, I can't see the question. So
Okay. Is there an association with vegan diet and PCOS?
Vegan diet and PCOS. Is there association with vegan diet and PCOS?
Could you maintain Priya?
Is there I didn't get the question.
Association with the vegan diet. Now there is a new diet system is coming, isn't it? Vegan diet. There is no milk product. It's called vegan diet. Gluten free, milk free.
Yeah, you can probably do a study of people and then say anything about it. Otherwise, it's not really the right thing. There's so many diets: intermittent fasting, vegan diet, and then you have the keto diet, and then the normal diet. So it's so confusing. Unless we have categorical studies saying that this really helps, I think everything else is just...
we have not come across anywhere taking vegan diet and increased incidence of PCOS. That's the one thing, that question they ask. Another one is there a difference in the genetics between lean PCOS women and obese PCOS women?
So actually, again, yes, sir. So the patients who are lean PCOS, actually, some of them may actually be having these lipodystrophies actually. So the one I showed actually was a very severe phenotype, that is generalized lipodystrophy. But actually, many people have these partial lipodystrophies, and we don't even recognize that they have it. So they mainly, you will see these people will have very thin limbs and more truncal, some fat will be there on the trunk. So these are kind of partial lipodystrophies. They're very mild, but they also have this insulin resistant and they can present with PCOS. So some of these, and then there is also the lean PCOS, also the patients with AMH mutations are known to have are obese, are lean and have PCOS. But the usual, as far as I know, the typical PCOS patient, as far as I am aware, there is probably not much difference between the lean and the obese one. But there must be some mechanism which we right now don't know. So, but I cannot really comment on that part.
So obviously there are a lot of subsets in what we call as PCOS. Even definition of PCOS is not accurate, is not limited to the ovary. It's a metabolic stuff, and now more data is being added. So probably a lot of subsets are there. You have the lean PCOS, you have the obese, and you have the hirsute, non-hirsute. So many different presentations as you see the phenotypes. So probably a lot of subsets are there. And you see so many PCOS conceiving without any help, without a problem, you know. There are patients like that also.
Okay, if there are no other questions, we'll go for the vote. Thanks. So this is my present duty. On behalf of the TAPISAR, I would like to thank all the faculties and moderators, Dr. Niranjan Chavan, Raghavendra Prasad, Dr. Devika Gunasila, Dr. Pratik Tambe, Dr. Nirmala Sadasivam, Dr. Jyoti Bali, Dr. Rohan Palsetkar, Dr. Chaitanya Nagori, Dr. Kannagi Uttaraj, Dr. Priya Bhave, Dr. Kunju Mueddin, Dr. Shagan Agarwal for sparing your time and participating in this webinar and making it a grand success. Also, I would like to thank the Merck Specialists of India for sponsoring this program, particularly Mr. Rajendra Mohan, Karthikeyan, and Vijay Raghavan, and Science Integra, Mr. Sheshan and his team for their excellent technical support and making without any problem. It went on very smoothly for this 4.5 hours. Thank you everyone.